approach to granulomatous lesion. Chairperson for the today's session is Dr. Alpa Dalal, HOD Pulmonology, Jupiter Hospital, Mumbai, Chairman Nodal TB Center, Sivri TB Hospital, and Dr. R.K. Sharan, Professor Pathology, GB Pant Hospital, New Delhi. Our faculties for the today is Dr. S. Datta Gupta, Professor St. John Medical College, Bangalore, and Dr. Sudhir Arawa, Professor AIMS, New Delhi. I'll request the participant to introduce themselves one by one.
Good evening to all. I am Dr. Agam Hans, a PG second year in MIMSR Ambala.
Good evening, everyone. I'm Prantika Gogoi from Jimhat Medical College.
Good evening, everyone. I am Dr. Kiran, PG, Regional Cancer Center in Tirunelveli.
Good evening, everyone. I'm Dr. Gokul, Topiwala National Medical College, Mumbai, second year PG.
Good evening. I'm Dr. Rashmi, second year PG from Kadamulla Medical College, Mangalore.
Today's moderators, Dr. Nisha Modi and myself, and webinar host, Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. Few reminders: if there is a connection interruption, low or no sound, kindly leave the meeting and rejoin. Please answer the poll question by tapping in the chat box, and please do not send the request for annotation to the presenters. Here are the few disclaimers. Few more. We are having the upcoming talks on 5th September, laboratory management including inventory management, LIS costing by Dr. Sujay Prasad sir, Technical Director, Newburgh Anand Reference Laboratory, Bangalore. And the next, after that is on 7th September, slide seminar on cervical cytology case-based approach by Dr. Hemant Kumar and Dr. Jennifer, CMC Medical College, Vellore. I'll request Dr. Datta Gupta sir to share his screen.
Yeah, able to see now?
Yes, sir. Yes, sir.
Yes. Good evening, everyone. It's been a pleasure and an honor. I thank Dr. Borges and Dr. Sumit Gujral for this opportunity, which we have been cherishing for long. I also thank the chairpersons, none other than Dr. Dalal, who is a very famous pulmonologist from Mumbai, and our dear friend Dr. R.K. Sharan, one of the finest pathologists we have, who is in GB Pant Hospital, Delhi. This entire, I also welcome the students, and we are going to learn from them today. So we are nervous, both of us. And my colleague, Dr. Sudhir Arawa, one of the finest gentlemen and a wonderful histopathologist and dermatopathologist, has actually collected all the cases. So all credit goes to him. So we'll start with these granulomatous inflammation. This is the disclaimer that's meant for teaching purpose, and we have collected data from our own experience, that's the cases and other things, and we have acknowledged wherever we have taken material from. There's no financial interest or conflict of interest. Now, the way that we'll go about this is that I'll first give a small introduction about granulomas. This is important because you would have learned granulomas as an undergraduate. So as postgraduate, there are certain extra things that you are expected to know. How much it helps you, question that you will learn in due course of time. And then we'll come to the cases. It's not possible to cover all aspects of granulomatous inflammation. We'll just give you some examples so that you can work on them as you learn. So first of all, we come to the definition of a granuloma. So basically, it's a collection of mature mononuclear phagocytes. It's called mature because the moment it's immature, you think of neoplastic diseases. And it is not necessarily accompanied by necrosis or other features like this. So where there is no necrosis, some people call it pure granulomas, and where there is necrosis and other features, they call, some people use the term complex granulomas. There are other definitions. It's a inflammatory response of the chronic type with collections of macrophages, epithelioid cells, and multinucleate cells. And so everywhere, what is important is whatever definition you take, it's a organized collection of mononuclear phagocytes with or without giant cells or necrosis and so on and so forth. So please note that the word epithelioid is often misspelled. There after L there is an O sitting between two I's and then there is a D. So epithelium, epitheli, then instead of there is OID. So that's one thing you have to remember. End result of granulomas is healing and repair, so you have fibrosis. So now we'll go to the next slide. Now if you see, the first time granuloma was used was by Rudolf Virchow himself. Most of the things that we are talking about took place in a span of 10 years between 1863 and 1873. So Virchow used the term granuloma for the first time. He had seen giant cells, but he never mentioned that there were giant cells as such. So he said there are cells with some 50, 60 nuclei that you see. But it was Theodore Langhans in 1868, he used the term giant cells. And we know that in tuberculosis, we use the term Langhans giant cell after his name, because at that time he described it in tuberculosis. Wagner described what he called epithelioid cells. Some people say it's Robert Koch and Cornell. They also use this name. But however, the first case of inflammation with epithelioid cells in addition to tuberculosis was described in a fungal joint synovitis by a person called Costa. It was in 1870-73 that Schuppel claimed three obligate cellular elements: giant cells, epithelioid cells, and you can see other things like necrosis. So in these 10 years, this thing happened. So just in case you forget how Virchow looked like and Theodore Langhans looks like, here are the two stalwarts. So the first thing that you have to understand in any granuloma is that important cell is the histiocyte. Now histiocytes generally have two major functions. One is antigen presentation and another is phagocytosis. The antigen presenting cells, the macrophages or histiocytes can present, but the cells that are specially endowed with antigen presentation are the Langhans cells and dermal dendrocytes. The phagocyte is known as a macrophage. Phage means eating up, macro is a little larger cell, so that's why it's called macrophage. And the macrophage has got various functions, including response in wound healing, in addition to its phagocytic, cytotoxic, and regulation of inflammation. The disorders of monocytes, histiocytes, or macrophages are divided into three categories. Functional defects, they are mostly hereditary, like in Gaucher's disease, Niemann-Pick, Shediac-Higashi. One of the other enzymes are not working properly or absent, so you get accumulation of various substances in these. Reactive responses, which are non-neoplastic, and then of course neoplastic like histiocytic sarcoma, Langerhans cells, histiocytic dendritic cells. Macrophages are generally, so what we are going to talk about today is mainly phagocytic cells and the reactive response. We will not delve upon the functional or the neoplastic diseases. So granulomas are related to phagocytic cells and they are responsive to certain external noxious stimuli. The macrophage is generally a large cell with a vesicular nucleus, and you can get a small nucleoli. Sometimes you do find certain gobbled up material in them. The Langerhans cells, on the other hand, are more characterized by the nuclei, which may have grooves. I'm sorry, I'll take this laser point, I believe. Yeah, they have these grooves, and the nuclei are irregular. Actually, they are folded, and that's why you have this grooved appearance. Dendritic cells, on the other hand, they are found especially in the lymph nodes. They often occur in pairs. They are more vacuolated than the centroblasts or the surrounding cells, right? And they have a small nuclei in them. So this is how the dendritic cells look like. So we are talking about these cells, not about this or this. Okay? So the macrophage, you have to know, they are embryonic in origin. They come from the bone marrow, hematopoietic stem cells, and they invariably get located in various organs in the body. Now these macrophages, which come directly from the embryonic stem cells, they are long, they live for a long time, and they can renew themselves. On the other hand, these organs also have monocytes which are circulating in the circulation, and whenever required, they enter into the tissues. These monocytes are short-lived and they come on demand. So you have two types of cells, the monocytes from the bloodstream and from the bone marrow directly in prenatal life. These cells generally go by certain names. Like for example, in the lung, they are alveolar macrophages. In the liver, they are Kupffer cells. In the brain, they are microglial cells. In the brain especially, this is important because the blood-brain barrier opens for a short period in the prenatal period, and all these cells populate them. The leptomeningeal cells are essentially those which have come from the bone marrow. Very rarely the brain opens up to welcome the other monocytes. Then of course in the intestine, skin and kidneys you have them. Now this is very important to note, okay? Then we'll come to the different type. So you have the embryonic derived macrophages. They're mainly tissue specific. They go into the bone as osteoclasts, microglial cells, alveolar macrophage, Kupffer cells, histiocytes, white pulp, red pulp, littoral cells, and so on and so forth. But in addition, when there's a whole lot of trafficking of movement, especially from the peripheral blood cells, where you have the inflammatory monocyte. These are short-lived, these are long-lived, but they have essentially similar function. So different tissues have different things. For example, the CNS and the epidermis, mainly the Langerhans cells, they are all the original from the bone marrow. Whereas in the intestine and the dermis, the majority are from the monocytes that come from the bloodstream. The remaining have a mixture of both of them. But when these are depleted, that is in the case of inflammation and so on, the monocytes jump into the scene and they populate those organs whenever required. These
Sir,
macrophages.
Can I excuse me, sir?
Yeah.
So there are some of the attendees calling that it's a very soft voice. Can you be a little louder, sir?
Now can they hear me?
Can you make the volume full? It is still not full.
Yeah, full.
Yeah.
Full.
Thank you, sir.
Okay. Now macrophages have got a variety of receptors. So they are one cell with perhaps one of the maximum number of receptors, so they have a variety of functions. Not going to this. But what you have to know is an activated macrophage is generally of two types, M1 and M2. The M1 is the classically activated ones by bacteria, by other organisms. They are pro-inflammatory. They result in a Th1 or cell-mediated response, and they function for host defense and anti-tumor immunity. M2 are alternatively activated by cytokines, and they regulate wound healing, the second part of the story. The first part is fighting the organisms. Second part is when that is done, tissue repair sets in, and M2 macrophages are actually for that. Now, M1 macrophages, you can do CD80 or INOS to identify them. M2, you can do CD163 or 206, 209 to identify them. Now, the importance of these two will come later. Morphologically, it's very difficult to distinguish two. Now, how do the macrophages become M1 or M2? All macrophages have got arginine. So, if they activate the INOS pathway, they produce nitric oxide and they become M1 macrophages, which inhibit cell proliferation. They gobble up bacteria and so on and so forth. Suppose they activate the arginase pathway, then from ornithine they produce ornithine and urea. They become M2 macrophages, and this helps in cell proliferation and repair. So you see, there are two types, M1 and M2 macrophages, depending on their function. So you have to understand what is good is M1 macrophages can therefore become M2, M2 can become M1 whenever required. So there is a good admixture of these two types of macrophages, and the cells can go from one to another. Okay, so the macrophages have got a function which is called SHIP, but in sampling, they either sample the bacteria or the area that has to be healed. Okay, they heal or inhibit bacteria, and then they present antigen. They are not very good at presenting antigen, but never mind. M2 is for Th2 or antibody, they present to B cells. M1 is for Th1 or cytotoxic, and they present to cytotoxic T cell. So you see, these macrophages do a lot of function that way. Now, how do you distinguish? Morphologically, is there difference? Well, in cell culture and all, they say the M2 are larger cells than M1. Okay, and it's very difficult to make out in tissue unless you do an immunohistochemistry. Now, in an infection, will you get M1 or M2 exclusively? No, you generally get a mixture. For example, this is in a cholesteatoma, and you find in this cholesteatoma it's in the healing phase. Although there are M1, which is identified by CD80, and M2 by CD163, there's a admixture of M1 and M2. There's a preponderance of M2 because it's in the healing phase, right? Now, this is in a non-necrotic and a necrotic granuloma, and this is in a non-granulomatous tissue. So, this is the stain for macrophages in general, CD68. This is INOS and this is CD206. So, you see, you can get a mixture of both of them depending on when it is required. Now, here we come, the macrophages, if they are unable to tackle the bacteria or the foreign material, they generally become more active and become what are called epithelioid cells. Epithelioid cells are so called because they form almost a syncytium. One cell joins another, there's almost a tight junction between all these macrophages as if they have formed an epithelium. How are they identified? They have an eosinophilic cytoplasm. They almost join each other, and they have a nucleus which is slightly elongated or irregular, and classically they are supposed to be shaped like a slipper. This is the sole, this is the toe end, and therefore in undergraduates we say that they are slipper like nuclei, but it's not necessary that you'll always find slippers. So you can find them round, they can find them oval, and you have a dot like nuclei in them, nucleoli in them. Okay. Please remember, the term epithelioid is used to indicate epithelial-like morphology. Various tumors are called epithelioid tumors, but they are not similar to the epithelioid cells in granulomas, which are essentially macrophages. For example, in picomas, epithelioid cells are not macrophages. They have origin from melanocytes and smooth muscle cells. Epithelioid gysts are gyst cells only. They are interstitial cells of Cajal. Epithelioid leiomyosarcomas are smooth muscle cells. So you can have a variety of epithelioid. The term epithelioid used to prefix tumors, don't mistake them for epithelioid cells of the granulomas, right? So how are they different from usual macrophages? They have a lot more lysozymes compared to the usual macrophages. They have interdigitating surfaces that lock with the surrounding ones, and they also have these cup-like depressions in the edges of most of these cells. So these are the features by which you identify epithelioid cells. They are rich in E-cadherin, that's why they join with each other, can do a stain. They also may have placoglobulin and other things. Sometimes they also have actin in them. So you see, this is how they become a tight granuloma or organized to form all these cells. So this is what you see in a granuloma. Now a granuloma is like the foyer of a medical college. A whole lot of people going in and going out. So it's not only just epithelioid cells with necrosis and the organism. You can have T cells, B cells, NK cells, neutrophils, mast cells, and even blood vessels. Whole lot of cells in them. One thing is, some studies have shown that the center of the granulomas, if it is necrotic, obviously have M1 cells more than. M1 are pro-inflammatory, they are more phagocytic, they secrete nitric oxide, so they are more killing in that way. M2 are in the periphery, they are more involved with healing, fibrosis and repair, and that is why in the periphery of granulomas you get fibrosis, central area necrosis. The M2 are more E-cadherin positive than M1. So you see, you have a non-epithelioid granuloma, then you have epithelioid, then they become necrotic if there is uncontrolled infection, the right amount of TNF is not there, then they become necrotic. On the other hand, if they have IL-13, TGF beta 1, then they become more towards the M2 and they become fibrosis. Some granulomas will have more of giant cells than the epithelioid cells, right? So we'll come to that. So what are these giant cells? The giant cells are generally because of homotypic cell fusion. Homotypic means similar cells fusing with each other. Now I'll ask you a question. Can you give an example of heterotypic cell fusion? Divyanshu, just give them 10 seconds. Give an example of heterotypic cell fusion. Two different cells fusing together. Any response?
No, sir, not yet.
No response.
Oh, you must go for it, asking for this egg cell and the sperm cells. Anyone thinking
Yes.
Is one.
that may be?
Yes, you are absolutely right. The best example is spermatozoa and ova fusing together to form the embryo. Yeah.
Yeah, someone has written it on the
Yeah,
chat
very
box.
good,
Yes.
very good, very good. So the giant cells are because of macrophages fusing with each other, which is called homotypic. This happens even in tumor cells. What is the size to call a giant cell? There is no definite size, but they are generally large. But some authors say they are usually more than 40 micrometers in size, 40 to 120. They may have one large nuclei or two or more nuclei. Generally, they have two or more nuclei. So you classify them as physiological and pathological. Physiologically, you have osteoclasts, syncytial trophoblasts, and megakaryocytes. Okay. Now, how many nuclei do megakaryocytes have? Just 10 seconds. Any of the students who are here today?
Single.
That is very simple
So
question. They must answer.
so actually there is endomitosis in that. Around 70, ma'am, sir, 1x to 72x, 72 times the uh, nuclear is increased, DNA is increased.
Yeah,
But
actually,
Endodipl-
megakaryocytes have a single nucleus that is lobated. But the amount of DNA, or yes, you are right, because of endomitosis,
Duplication.
it can triplicate and it can go larger and larger. But unfortunately, in tissue sections, because they are cut across, you find as if they have multiple nuclei. Please remember this when you are doing, when you are looking at megakaryocytes. Don't make the mistake of saying they have multiple nuclei. They may have 64 DNA or 32 copies of the normal complement of DNA in a human cell. Okay. Pathological could be
excuse me, sir.
inflammatory. Yeah.
Sir, then why it is a fusion? How can we call it a fusion when there is no?
No, it is, you see, that's why it is generally but not limited to. So it's not always due to fusion. Means it's a large cell actually. Okay. So that's why megakaryocyte is an example of it. Now among the inflammatory cells, inflammatory giant cell, you have foreign body, Langerhans cells, Anischkow cells, and Aschoff cells you have in rheumatic heart disease, two-tone giant cell in which there is a central cellular area with nuclei, and then you have again cytoplasm in the periphery. In Langerhans cells, they are arranged in the periphery like a horseshoe or all around like a wreath. Foreign body, they are just scattered all over. What is this type of cell called? Anybody? As an undergraduate, we expect 1, 2, and 3. And if they can tell this also, very good. So now you tell this extra one. Anybody? Okay.
So few replies are there. Osteoclastic and crouton cell.
Very good. This is called a crouton giant cell. Crouton giant cell is a giant cell with lot of cryptococci in them. So cryptococci looking like two-tone giant cell because the nucleus are in the center. They are called crouton giants. Anyway, croutons are nothing but, you know, those breadcrumbs that they put on top of soup and other things, the small pieces of bread that are fried. Okay, this is crouton giant cell. Yeah. So pathological viral infection, you have herpes, cytomegalo, Warthin-Fingaldi, and respiratory syncytial virus. So these are the giant cells seen in viral infection. In tumors, osteoclastoma, Reed-Sternberg cell, anaplastic tumor giant cell. They may have just one nucleus, which is very large. The cell is large, and of course, they have irregular nucleoli and so on and so forth. And you can have a rhabdomyoblast. Then there are others, neonatal giant cell hepatitis, a large hepatocyte with 3 or more nuclei, and a muscle giant cell. So you see, this is the list of the various types of giant cells that you see. If anybody asks you as a postgraduate, at least try to tell some of them and classify like this, you'll be able to remember most of them, right? So this is a crouton giant cell which has got this nuclei here. These are all cryptococci, right? And it's seen in cryptococcus. Okay, so you do a stain, you'll find PA stain is enough. What are Titan cells? Anybody can tell? Okay. Anyone? Okay, Divyanshu.
Yes, sir.
Nobody has said no?
No.
Okay. Titan cells are large cryptococci, more than 15 microns in size. More usual cryptococci are 2 to 4 microns. So these large cells, it's very important. If you see them in tissue section, you please tell. We have a thick capsule. The importance is they are seen in the lungs. They are more pathogenic. They cause dissemination, and they are resistant to the usual antifungal treatment. Okay. The other things that you must remember in giant cells are inclusions. This is an asteroid body. Schumann body are calcified. Then oxalate crystals you can get. Cholesterol crystals and Hamasaki-Wiesenberg bodies, which can stain like almost like yeast with a silver stain, but they are not that. They are mainly lipofuscin and other material. All this can be seen in sarcoid, right? But they are not specific. You can see these in tuberculosis also. You can see in fungal infections. But anyway, they are helpful in the diagnosis of sarcoid. Can anybody say who this is? No one.
No reply, sir.
He is Shaman. Just in case you haven't seen him earlier. Okay. He is a Swedish dermatologist and he described the Shaman bodies in sarcoidosis. Now, so you have these macrophages. They become giant cells. If MCSF rankle is there, they become osteoclast. If IL-6 and interferon gamma is there, they become foam cells and two-tone cells. If interferon gamma and IL-3 is there, they become Langerhans giant cells. If IL-4 and IL-13 is there, they become foreign body giant cells. So this is how the different giant cells are formed. Okay. So depending on the cytokine that is available, the cells become like that. So certain terms in granuloma, histiocytic aggregates are loose aggregates of histiocytes. Ill-defined granulomas are the small cells loosely arranged. This is an ill-defined granuloma composed predominantly of giant cells. This is an ill-defined granuloma in the liver. It looks like a granuloma, but not so well defined. These are well-defined granulomas. If the cells are little separated out, they are called loose granulomas. If they are compact, they are called compact granulomas, typical of sarcoidosis, right? Focal granulomas are granulomas located separately in small areas. This is in sarcoidosis where they are perilymphangious, like and bronchocentric. Okay, so this is focal granuloma in tuberculosis. Diffuse granuloma is where they are not well defined. Classical is lepromatous leprosy. So you have focal granulomas, diffuse, compact and loose. Compact granulomas without necrosis are called hard granulomas in the case of tuberculosis. With necrosis, they are called, sorry, there's something somebody wants. Hard granulomas, they are called, I'm sorry, I'm supposed to do something.
It's not moving.
Yeah, because somebody has asked to share or something like that.
Oh.
Okay, so hard granulomas, and if they are necrotic, they are called soft granulomas in tuberculosis. This is a necrotizing granuloma, this is a non-necrotizing granuloma. Non-immunological granulomas are those which do not have lymphocytic cuffing. Immunological granulomas have a lymphocytic cuffing. So these are the different terms that are used. Discrete granulomas are granulomas separated from each other. They are single giant cell systems. You have epithelioid cell and maybe one giant cell. Confluent granulomas are granulomas which join with each other with multiple giant cells. So this is typical of sarcoidosis, confluent granulomas are typical of tuberculosis. Spindle cell granulomas. Macrophages, which become spindle cells and in the form of a granuloma or spindle cell granulomas. Typical is histioid leprosy. Right? What are these granulomas? Anybody can say? Anyone?
Sir, donut granuloma.
They are called donor granulomas, but the correct name is fibrin ring
Fibrin ring.
granulomas. This is a fibrin ring. Okay. This is a Martial scarlet blue stain, and this is just a PA stain. You have a fat in the middle, epithelioid cells all around them, and the middle of the epithelioid cells you have some fibrinous material. Okay. These are fibrin ring granulomas, typically seen in Coxiella burnetii or Q fever, but you can get them in hepatitis A, CMV, EBV, reaction to certain checkpoint inhibitor therapy, especially seen in the liver, bone marrow. What is this granuloma? Fat with these cells. This is called an oleogranuloma or fat granuloma, typically seen in NASH. Okay. Xanthogranuloma, and this is xanthogranulomatous inflammation. There is a difference between the two. This is not a reactive process, just a juvenile xanthogranuloma. It's called a xanthogranuloma, but it's mainly a neoplastic process. Whereas this xanthogranulomatous inflammation seen in urinary tract, ovaries and gallbladder typically is the granulomatous inflammation we are talking about. They have foamy macrophages, giant cells and cholesterol clefts. This is a bile granuloma. So bile granulomas are nothing but encrustated bile with a granulomatous response seen in biliary obstruction. So you can have in the liver ill-defined portal granulomas, bile duct centric granulomas and zone 3 granulomas. So bile duct centric and bile granulomas are seen in biliary obstruction and PBCs. So you have different types of granulomas, much more than just necrotizing and non-necrotizing. Fibrin ring, you had the oleogranulomas, spindle cell granulomas and bile granulomas. Okay. Now they are named as granulomatous disease, but they are not conventional granuloma. Like for example, giant cell reparative granuloma is a benign reactive intraosseous process where you get lot of osteoclast giant cells and macrophages, but they are not included under granulomatous inflammation. Plasma cell granuloma is a benign lesion composed of mainly plasma cells and some histiocytes seen in the oral cavity, tongue and gingiva. It's called a plasma cell granuloma, but it is not the granuloma we are talking of today. Okay. Chronic granulomatous disease, that is CGD, it is because of NADPH oxidase complex. There's a problem there, and therefore they cannot generate superoxides. And there is a granulomatous inflammation. The neutrophils do not work, the macrophages do not work, so they convert to granulomas, the macrophages, and you get widespread granulomatous inflammation. But this is not included in the inflammatory granulomas and other granulomas we are talking of today. So non-necrotizing granulomas, there is a whole list from A to Z, starting from atypical tuberculosis to zirconium exposure. For there is an easy way, think of RBCs and LDH, foreign body reaction, berylliosis, Crohn's disease, sarcoidosis, typical sarcoid type granuloma, leprosy, drug reaction, hypersensitivity, pneumonitis. These are the common types, and in some countries you can add toxoplasmosis. RBCs, yes, and LDH. Okay. For necrotizing, you have caseating, coagulative necrosis, fibrin necrosis, and different types of necrosis. They are mainly either because of infections due to bacteria, parasites, viruses, or because of immunological mechanisms or vasculitis. These are the two major causes of necrotizing granuloma. So you have non-necrotizing, necrotizing, focal necrosis, suppurative, and so on and so forth. We'll come to each one of them. Please remember, necrotizing is either because of an infection or because of autoimmune or vasculitic process. These are the two major causes of necrotizing granuloma. In cancers, you can get granulomas, one as a reaction to the cancerous material. Classical example is to keratin. Then granulomas associated with cancers, like in renal cell carcinoma, you can get granulomas sitting in the middle of the cancer. Granulomas, even in breast, you can get. Granulomas in lymph nodes, you can get either with metastasis or without metastasis. Without metastasis, it's supposed to confer good prognosis. All these granulomas are generally non-necrotizing. The location of granulomas is important for diagnosis. For example, in the lung, if you get necrotizing, it's always an infection. Tuberculosis in our country, in addition, it may be other fungi. Lymphangiocentric or next to bronchial markings, if they are there, likely to be sarcoid. Perivascular, majority giant cells with some talc-like material, think of talc granulomas. If it is in the vessel wall, it's a granulomatous vasculitis. Within the alveola, it may be intra-alveolar loose granulomas. Within the interstitium, if it is in the peribronchial area, expanding and closing the lumen, and if it's peribronchial, which is loose, you have different etiologies. So it could be tuberculosis fungal, if it is lymphangiocentric sarcoid berylliosis, if it is perivascular, non-polarizable sarcoid or berylliosis, polarizable talc, granulomatous vasculitis, autoimmune or systemic vasculitis. If it is within the alveoli, think of cobalt. In the interstitium, tight granulomas. In addition to sarcoid, you could think of hot tub lung disease because of MAC or avium intracellulare. If it is pushing into the lumen, granulomas, hypersensitivity pneumonitis. It is loose, not pushing, Begasosis. But these are not typically seen in all of these cases. You may see a case of sarcoid without these typical findings. Please remember that. You have to use the clinical, radiological and other findings available with you. Okay. In fact, there are various algorithms in which you can do these, look at these granulomas. So we come to the first case, case 1. Kiran, can you just take it up, please? The slide for diagnosis. What did you see?
So it's a section from fibroprogenious tissue.
Mm.
Shows a collection of multinuclear giant cells rimmed by lymphocytes.
Okay.
In the center shows foreign body.
Okay.
So probably maybe attack granuloma.
Can others mute, please? Okay, please.
Sir?
There's some sound coming. Okay, okay, disturb. Okay. Yeah. Good. And this is polarizable material.
Yes, sir.
Okay. So what is that? Foreign body.
Foreign body. Yeah.
Okay.
Probably talc.
Okay. Okay. You know, in this granuloma, the most characteristic feature is almost entirely made up of giant cells. They are of the foreign body type. They are not Langerhans type. They're number one. Whenever you see a granuloma full of giant cells, mainly of the foreign body type, search for a foreign body. It is unlikely to be infective, because if it is infective, you would have found epithelioid and other cells. Secondly, you will notice there's hardly, the lymphocytic infiltration is sparse. So it's a relatively non-immunological type of granuloma, not much. And then of course you are finding the foreign body. Now in the foreign body, Kiran, you are finding most of them are rounded.
Sir.
If they are rounded and they are almost similar to each other, almost similar, some are cut across, it is very unlikely to be talc.
Okay, sir.
Is talc, it does not look like this. So you see, this is a suture granuloma.
Okay.
Okay. So now you see sutures, if they are like this, you see, two things you have to see in suture. Say talc is like this. Okay, Kiran? They are irregular. Now the sutures you'll find nowadays most of the sutures are rounded almost similar to each other. These are called monofilament sutures. They are either vicryl or proline sutures. Okay, so these are the common sutures. Both of them you can polarize and you can find them. There are other foreign bodies that you can get. You can get gel foam, PVS sponge. These wide openings are the ones you get in mesh, polyester or polypropylene, or sometimes you get silicone dressing. Chrome gut you get rarely, silk you will get, they are dark in color and they also polarize. Cotton you don't see. Can anybody tell what is this lesion? You are finding giant cells, little inflammation and this hyaline like material. You often get them. Anyone? Collagen, okay. Somebody else? See, when you find a lesion like this, you search and search, you will invariably find vegetable matter. There is serious red staining. This is called, what is, sorry, this is called, I think Bindu has said, pulse or hyaline granulomas. The word pulse is meant for legumes or pulses. So vegetable granulomas are called pulse or hyaline granulomas. You see them because of this hyaline like material in them. So remember, always search for this. Sometimes you will not get this always. You can get tattoo granulomas where you get all this. Okay. And what is this? Anybody? This is a granuloma, foreign body type, hardly any cell, no lymphocytes, and you're finding this bluish gray material. Anybody?
Some needle-like crystals are there, and that
Gout.
forming around them, subepithelial.
Yeah.
Gout.
This is polarized. This is if you used a red interference at the back. This is how it looks. Yeah, many people have said, Piyush and some other people, Utsav has said that. Yeah, this is gout, urate crystals. Right? So this is gout. Okay, good. So now we come to case 2. Agam, can you take this?
Yes, sir.
Okay. Or let's tell one of the ladies. Rashmi, take it. Rashmi, take it. Let's see.
Case 2,
Okay.
18-year-old boy presented with cervical lymphadenopathy, lymph node excision done for histopathological examination.
Yeah, what are you seeing?
Section shows lymph node tissue with multiple necrotizing granulomas.
Okay.
So in this cover, we can see the necrotizing granulomas with composed of epithelioid histocytes, some
That's it.
giant cells
Okay.
surrounded by lymphocytes.
Anything else here?
Langan type of giant cells are seen.
Anything else, Rashmi? Important thing is they are becoming confluent. See? This granuloma is joining with that and all. That's an important finding. Necrotizing with confluent. Yeah, okay. Yeah, yeah. Very good. Anything else, Rashmi, you want to add? Rashmi? Can you hear me?
Yes, sir.
Yeah. Anything you want to add further?
About central part.
Anything else you want to add?
Caseous necrosis.
Gaseous necrosis. Okay. Anything else? What has happened here? Here you are not seeing anything, no?
Yes, sir.
Most probably it has liquefied here. So you can get liquefaction. Okay. What is this cell? This is a typical Langerhans cell. Okay.
Also,
Also check.
And what are you finding here? This is also granulomas, but it's looking slightly bluish because there may be some inflammatory cells. And this is the same thing going on. Okay. So is there what is your diagnosis? Most likely
Tuberculous lymphadenitis.
any differential?
Uh, it could be caused because of the fungal infection also. Similar findings can be seen.
Etiology is tuberculosis. Anything you'd like to do?
Yeah, Nielsen staining for the acid fast bacilli.
Okay, so you think it's tuberculosis. It is negative. So what do you think it is? Anything, Rashmi?
Gene expert.
Can yeah, PCR can be done to confirm.
Okay. Anyway, in our country, no, we don't have to do the other things. Usually, it's considered as tuberculosis, and I'm sure with the clinical findings and all, in most places, if they can do the other tests, well and good. If they don't, sometimes they treat empirically for tuberculosis. Now, this is a reticulin stain. What does it show?
We have very high incidence of drug-resistant TB, so gene expert should be done in all
Yeah,
cases of,
yeah,
to confirm and also to rule out drug resistance.
very
If I'm
good.
present.
Yes. Ma'am, we'll give you the cases now. So this is the reticulin stain. In sarcoidosis, no, usually it is reticulin rich, whereas in tuberculosis, because of necrosis and destruction, it is reticulin poor. In sarcoidosis, it is usually reticulin rich, because there's fibrosis. All this immunostaining doesn't help. You can get CD4, CD8 and so on. This is to show you all our macrophages. So necrotizing granulomas, you have different types. I told you once again, remember there are two main etiologies. The necrosis can be rounded or defined, irregular, somewhat stellate. It could be geographic, and it could be basophilic with fibrinoid material, geographic with eosinophilic areas, could be palisaded, could be stellate but uniformly eosinophilic. So now, does the shape help you? It does. This is, for example, this is seen in tuberculosis, this is seen in atypical mycobacteria, or you could get in cat scratch. These you'll find, see, bluish in them, right? It could be seen in cat scratch disease, mainly stellate with basophilic areas because they are neutrophils. Okay, this typically, if you get fibrinoid with geographic areas and blue, think of vagus. If it is like this, eosinophilic and geographic, think of sarcoid, which is necrotizing but is rare. You can get it in tuberculosis. Palisaded, it's mainly rheumatoid or diseases. And it's stellate but uniformly eosinophilic. You could get in a variety of conditions. It can also be an infarct in a leiomyoma or some other thing with granulomatous inflammation. So the shape of the necrosis helps you. Then you have caseous necrosis, which is uniformly granular, coagulative, fibrinoid, basophilic, suppurative if there is neutrophils, granular and eosinophilic will be caseous, collagenolytic are more homogeneous, neutrophilic. Then what do? You think of certain conditions. In caseous, think of tuberculosis or fungal. Coagulative, think of one of the vasculitis. Fibrinoid, vasculitis, autoimmune. Basophilic, vagus. Suppurative, think of fungi always or parasite. granular eosinophilic, this collagenolytic, then you have got these diseases which called there are certain group of diseases which occur mainly in the skin, granuloma annulare and so on. Neutrophilic, again think of fungi. Then you can do special stains to identify them. Sometimes you will not get. Please note, search for granulomas near the blood vessels. If you are searching for granulomas near blood vessels, look for granulomas elsewhere. With necrosis, you can get this in sarcoidosis. Okay. If there is fibrinoid necrosis in the wall of the vessels, it is likely to be an autoimmune disease. If it is basophilic, think of vagus, right? If it is necrobiotic or collagenolytic granulomas, like I told you, if it is blue in color, then if you do a mucin stain, if it is rich in mucin, then it's a mucinous necrobiotic granuloma. Think of granuloma annulare. If it is rich in neutrophils but no mucins, think of vagus or rheumatoid vasculitis. Blue granulomas. That is, they are mainly blue in color. If it is eosinophilic, then it's typical collagenolytic. It could be necrobiotic xanthogranuloma, rheumatoid nodule, Church-Strauss, or necrobiosis lipoidica diabetica. It depends on the location and other things. Sudhir will talk about them later. You also have elastolytic granulomas where the elastic tissue is destroyed, right? You have two types, elastolytic giant cell granuloma and actinolytic elastolytic granuloma. These are the two. Ma'am, can you come over and show the tuberculosis cases?
Yes.
I'll stop sharing the screen.
So I have 3 cases, and thank you so much. Really enjoyed all the different granulomas, and there's so much to granulomas. The first time I realized. So let me show a clinician's perspective. How do we see cases, and when we refer the patients for a histological diagnosis? Along with that, what other investigation we should send, and how a clinical picture will help you as a pathologist, talking or discussing with your clinician colleagues to decide or come to the final diagnosis. The young lady, 28-year-old, she had TB in the past, March 22, was treated at a native place. Again, she had recurrence of symptoms in May 2022, fever, weight loss, and typical symptoms. And so she was treated with AKT again. August 22, she detected to have pleural effusion, and she was started on first-line anti-TB treatment. She also had recurrent abdominal symptoms. Now we investigated her. This is the X-ray chest. You can see here, not much is. Yeah, I want to see the. So the X-ray chest, what we normally see is try to look at presence of any lymph nodes. So here there is no obvious lymph node that you can see. Let me just see the pointer.
You can click on the right side of the mouse. You'll get pointer options. Just click on the right side of the mouse or both fingers on your touchpad. Otherwise, you can use your arrow.
Okay, I'll use the arrow.
Yeah.
I'm able to split the arrow. Okay. So this is commonly lymph nodes you see here in this area. It's called paratracheal area, right and the left paratracheal, and the hilar area, the right hilum and the left hilum. And so here the paratracheal and hilar area look normal. We try to look at the costophrenic angle, costophrenic and the cardiophrenic angle for presence of any pleural effusion. We try to look for any lesions in the parenchyma. So we divide into 3 zones. This is upper zone, mid zone, and lower zone. So here you can see more or less the X-ray looks normal except for some possible abnormalities in the upper lobe area. Now we did CT scan for this patient and she had abdominal nodes also. We biopsied that, but the culture was again inconclusive. So we somehow wanted a diagnosis because it's the third time she's got TB and she was not clinically responding. So we did the PET CT scan and you can see here there is this right upper lobe lesion which is showing a good uptake. Her SUV was pretty high, more than 8. You can see here the hilar lymph node, which is having uptake, which was not evident on the chest X-ray. And this is the same lesion in the right upper lobe. So ultimately, we decided to biopsy this lesion, do the histopathology, and send it for gene expert. So one important thing here is whenever we are suspecting TB clinically and radiologically, it is very important to send the tissue, one in formalin for histopathological evaluation, and second sample simultaneously has to be collected in normal saline or sending for gene expert AB smear, AB culture. And if you are suspecting anything else, then bacterial culture or fungal culture. So that is very important because many times we get histopathological confirmation of tuberculosis, but that's not enough for us as clinicians. We have to rule out drug resistance. And culture is also important because sometimes non-tuberculous mycobacteria can also get similar kind of granulomatous inflammation. And unless we do the culture, we will not be able to differentiate. So this is very important. So here we did see necrotizing granuloma on pathology, and gene expert unfortunately was inconclusive because it was just trace, and we are waiting for the culture report to come. Now, second patient, a 65-year-old male, known case of type 2 diabetes, came with fever, cough, and weight loss. And sputum evaluation was done. Being a diabetic and having cough, fever, weight loss, the commonest diagnosis would be TB, but sputum gene expert was negative. Then here, because he was elderly man and he had got his USG abdomen and CT scan done at his native place, and so there could be a suspicious of lymphoma needs to be ruled out. Now here on the CT scan, you can make out that there is this paratracheal lymph node, a big lymph node. Another lymph node you are seeing, and this is in subcarinal area. So it's a large lymph node, and along with that, you are seeing cavitated lesion in the parenchyma. So with this cavitated lesion, diagnosis of tuberculosis was much more likely. But we did the bronchoscopy, and here with the bronchoscopy, we did endobronchial ultrasonography, that is called EBUS, and did the fine needle aspiration biopsy and aspiration both. So actually here in BAL, we got gene expert positive and it was RIPA sensitive. And in EBUS, we saw non-necrotizing granuloma. So sometimes in tuberculosis also, we can get non-necrotizing granulomas. So this patient was a case of drug-sensitive TB. Now, it is very important for us clinician when we are doing a invasive test, it is better to collect sample from multiple areas and send it for multiple tests. So that's important because we cannot repeat the test like bronchoscopy or EBUS repeatedly. So it's better to send the tissue also for culture as well as histopathology, and BAL sample for cytology as well as for the microbiological evaluation. And this is a third case, a 30-year-old female. She presented with cervical lymph node. It was biopsy proven TB and drug sensitivity proven on the gene expert earlier. If she had a cervical node which we could biopsy, it was very easy to biopsy. But after 3 months of TB treatment also, there was no clinical and radiological response. So we repeated a CT scan chest. It showed multiple mediastinal lymph node. And in CT abdomen, it showed multiple abdominal lymph nodes, and there was obstruction of the common bile duct. And she developed jaundice. So her bilirubin was 6. So biopsy of the abdominal lymph node was done. So how non-invasively you could do a biopsy, a less invasive procedure. So we did endoscopic ultrasound through the esophagus. We did the biopsy. The histopath showed a necrotizing granuloma, and gene expert again proved that this is a drug-sensitive TB. So these are 3 cases. This is here. You can see the X-ray in this patient. See this paratracheal region. It is showing enlarged paratracheal lymph. So she had paratracheal lymph nodes, both left as well as right. And this is the X-ray which is done after 3 months. And since it is not showing response, we had to do the CT scan and repeat the test. So these are 3 cases of tuberculosis that I had to share.
Thank you, ma'am, for those cases. I think what is most important point that you have said is that when you get the tissue, please send it to for proper investigation in addition to pathology. I think that's a very important lesson that all of us.
If I permitted to say
Yes,
one
Dr.
more thing,
Sharan, please.
one very important thing Dr. Dalal has said, and that is very important for all the pathologists to do, that the upfront drug sensitivity. Even in the National Tuberculosis Eradication Program, they said it whenever you are testing for anything tissue or anything for tuberculosis, send it for CBNAT, for rifamycin and INX sensitivity. So nowadays, for pathologists to diagnose tuberculosis is not a big deal. We have to give upfront to the clinician, and sending the tissue to CBNAT or the gene expert equivalent or any platform to say that before the start of treatment of ATT, clinicians should have a report with them whether it is a rifamycin sensitive and INS sensitive or not, because that is the crux of the thing for the whole of the tuberculosis treatment, and it is aligned with the National Tuberculosis Eradication Program. So that I wanted to tell you. This is very important point that you highlighted.
Very important point, sir. And see, generally when a pulmonologist sends you the sample, the pulmonologist is aware. But many times you will get samples, extrapulmonary sample from surgeons, and that's where when they have low biopsy suspicion of TB, they would end up sending the sample just for histopathology, and we have lost the opportunity to test. And this is still happening very commonly. So as a pathologist, when you talk to your surgical colleagues, you have to make them very, very aware that even if you have low suspicion of tuberculosis, please do send the sample for gene expert and AFB culture in the same sitting.
Thank you, ma'am.
And another point which is very important, that all the tuberculosis patients who are on ATT, even then the drug is sensitive to them, many times the cervical lymph node or any other the abdominal lymph node or things, in first initial 3 months, 4 months, even the lesion size can increase despite being the drug sensitivity. And that is another very important point, because of so much necrosis by the drugs and imbibition of the osmosis, the size of the lymph node tenderness, they increase, and the clinician many times think that it is not, as in your third case of thing, you have repeatedly done different methodology of aspiration and doing, and then finding again that it is a sensitive. So this is the thing which pathologists should keep in mind, that despite the treatment which is standard protocol with adequate compliance, everything, the size of the lymph node can increase in some of the cases. So that point another. Yes.
So iris is very common, and it's seen more in lymph node TB. It's seen more commonly in CNS TB and pleural TB.
Yeah.
I think now we'll tell Sudhir to take over the other cases. Yes, Sudhir, please share your screen.
Yes, thank you.
Ma'am, you can stop sharing the screen. Yeah.
Yes, yes.
Yeah, okay. Sudhir.
I stopped the screen.
Okay, Sudhir, you can share.
Yes, sir.
Yeah.
Yes, you can see now. Yes.
Go down to the case 3 onwards.
Case 3. who will be taking the case 3? May I know the name?
Agam.
Yes, sir.
Yes.
Sir, middle-aged male presented to pulmonary medicine OPD with complaints of shortness of breath and fatigue since 3 months. Recently, he developed blurring of vision and papillary skin lesions on extremities. Biopsy from lung for interpretation.
Agam, I will not go to the next slide. By looking at the history,
Yes, sir.
what do you think?
Sir, it looks like
Patient,
an autoimmune disease, sir, involving multi-system.
why not
Blurring of.
disseminated lesion? Why you thought of autoimmune?
Sorry, sir.
Why not a disseminated lesion, disseminated infectious lesion?
Uh,
Is there any possibility?
Sir, fever would.
Fever can occur, yes. Even in autoimmune disease, you will have fever.
Fever, yes,
Even
sir.
in disseminated infectious diseases, you will have fever. So when the patient is having multiple lesions, why the clinician thought that I will take biopsy from the lung?
Why not from the skin, Agam,
Usually
that's
when,
what he's asking.
yes, why not from the skin? I agree that he has a blurring of vision. You cannot take biopsy from the heart, from the eye.
So, so chances of finding a granuloma might be higher in older lesions, sir.
Because we are talking about granulomatous lesions, we'll think only about granuloma. That's great, good. So, Agam,
Yes.
I'll just ask you one thing. So, Professor Siddharth Dattagupta sir has beautifully, so you are very lucky to have sir on board and listen to his lecture. So, thing is, whenever you have a granuloma, think that you are a granuloma. How often do you see granuloma in a routine day-to-day life in your laboratory? How often do you see?
Sir,
Either
very
the
often.
how often? Maybe 1 to 2 cases per day.
Yes, sir.
Right? All of us. So it's
Yes.
thing is the granulomatous lesions or diseases of any system. It is one of the most common, even in remote medical colleges or hospital, wherever you will see 1 to 2 cases of granuloma. Right?
Yes,
How
sir.
often are you satisfied with your diagnosis once you see and report a granuloma? How often you are right? Think that yes, I have seen 2 cases today. All my 2 cases are 100% right, correct diagnosis. I'll give correct diagnosis. How often do you feel like that? Huh? You will not follow. So why I am telling you this is, see, identifying granuloma, pathologists should not be only limited to the slides, So it is a bridging field for both clinicians, okay, and the basic pathology. You have to identify the disease, okay. You have to, instead of clinicians, if they are having 100 differential diagnoses, it's your duty to narrow it to few differential diagnoses, carry out further special stains or necessary other investigation to come down to the diagnosis. If possible, you have to direct the clinicians for proper patient care and management, right? So granuloma, right? See, granuloma, if you think n number of diseases can have granuloma, name any diseases, somewhere or the other they might show granulomatous inflammation, right? So because in this patient, he is a middle-aged male, I'll just go about, he had a presence of shortness of breath on clinical history, right? So
Yes, sir. Sir, and
that's
the
why,
history is probably long, so chances of disseminated infection is less likely.
fine. So why? Because he is having fatigue, shortness of breath, fatigue since 3 months. It's quite acute or subacute kind of it. Quite during 3 months duration. If you are suffering, you also feel, it's a long duration suffering. That's what the clinician thought, okay, we'll take biopsy from the lung. So we'll see what biopsy shows.
So there,
Sir,
another point, Agam. See,
Yes, sir.
whenever such a thing happens, obviously he would have undergone at least a chest X-ray.
yes.
Yes, sir.
And there must have been something in the chest X-ray And of course, other investigation it might have prompted for a lung biopsy. But okay, tell.
So one thing you should remember, Agam. So whenever there is a shortness of breath and pulmonary involvement, one a routine X-ray and high resolution CT of the chest is must. To see the disease distribution and its severity. Okay, that is after that, clinician thought something else, some diseases of the lung. So he took biopsy, and this is the biopsy what you are observing. I want your description.
Yes, sir. Sir, the section examined shows well-formed, discrete, naked granulomas along the lymphatic.
Agam, try to identify the tissue first.
Sir,
Divyanshu, sorry, Divyanshu, there's some sound coming, no? Are you all hearing? Background, yeah.
Background sound is coming. Yes.
I think, okay, now it's gone.
Yeah.
Yes.
Yes, Divyanshu, can you see my arrow?
Yes, sir.
Yes, sir.
What is this?
So these are lymphatic channels, sir.
That's what I told you. You have to identify. I already told you that biopsy is taken from the lung.
From the lung.
Right? What are these structures?
Alveolar.
These are all alveoli. These are each one thing. The hexagonal structures are alveoli. They are separated by interalveolar septae, and this part of the lung looks perfectly normal. Perfectly normal. So first thing all of you should remember is try to identify the tissue first from where the biopsy has come. So if it is come from pulmonary, obviously you will know that it is from lung, but most of the time what ma'am said, it will be from surgery where they will not even write anything on the form. You have to assume everything, right? So identification, as a resident, you have to identify the parent organ and tissue first. Fine, this is a lung. You are confirmed that this is a lung?
Yes, sir.
Do you see alveoli anywhere else in any other organ other than lung?
No, sir.
The alveolar structures. Okay, then what do you see?
Agam,
pathology.
you should be very careful. Supposing there is blood in those spaces, no?
Yes.
Don't mistake them for cavernous hemangioma or
Cavernous
something.
hemangioma.
Okay? It looks almost like that. Sometimes the new residents sometimes mistake. Okay.
Yes.
Very
And
good.
one more important
And
thing.
in the edge.
Edge, yes.
What is that edge?
What is happening here? Can you describe this?
Where, sir?
The pathology. What are you seeing here? What
sir, we are seeing well-formed, discrete, naked granulomas along the periphery and just beneath the pleura, sir.
Beneath the pleura. And here they are discrete. Very good.
And sir, in the next slide.
No, I'm not going to next slide. Tell in this slide only.
Sir, they are naked granulomas, sir, without the lymphocytic collar.
Okay.
And sir, surrounded by fibrosis, sir. Lot of fibrosis.
There is a lamellated fibrosis, right? You want to comment anything other than this and this magnification?
Sir, punctate necrosis is also visible in areas of calcification, sir.
Where?
Sir, toward just beneath, yes, sir, beneath the pleura, sir.
Here?
Yes, sir, this
These
one.
are all multinucleated giant cells. These are well-formed epithelial cell granulomas. You said discrete, located in the subpleural region and also somewhere in the alveolar parenchyma. See, lung parenchyma in the alveoli. Each granuloma, you said they have poor lymphocyte cuffing. See, identify each and every component of it, right? And some of the granuloma, so majority of the granuloma, they show some kind of a lamellated fibrosis, which is present at the periphery. And do you see necrosis?
Sir,
you cannot make out at this magnification. You want to go to higher magnification.
Yes, sir.
Right? Okay, I'll go to the next slide. Yes.
Sir, here the granulomas are trying to coalesce, sir.
Yes.
Sir,
Yes.
and we
Can you see my arrow?
Yes, sir.
Take out this granuloma. I can easily separate this granuloma, and this granuloma.
Yes, sir.
Okay. So do you still call it as a confluent granuloma or discrete granuloma?
Sir, they're trying to coalesce, sir. I would say confluent granuloma, sir.
Would say granuloma. Okay. So confluent. Okay. Next slide in higher magnification.
Sir, I thought that
Agam,
yes, sir.
Agam, are these granulomas located near blood vessels or bronchi or just lying here there?
Is there
Sir,
any peculiar distribution or they are just randomly present everywhere?
sir, along the lymphatic channels and blood vessels, sir.
How do
Where
you
is
see?
where is the lymphatic?
Can you show lymphatics here? Can you see lymphatics and HND in lung? Clearly, can you make out? What structure is this, Agam? Yes? What, Agam? Can you hear me? What structure is this?
No.
There is
Sir,
one structure. Yes.
sir, I'm not sure, sir.
Right. So I'll give you a hint. You just have to think, it is a round structure, tubular thing. It
Yes,
has
sir.
got a thick wall and few
Bronchi
RBCs in the lumen. What structures it could be?
vessel, sir.
Yes, it is a vessel. So you need to identify as a resident, you need to identify the native structures. How to identify? All of you should know the histology must. So it is a vessel. There is a full granuloma here. And what structure is this?
Sir, nerve.
Why do you say it is now? There is a
Uh,
lumen here. There are a few RBCs.
sir, neurovascular bundle, I would say.
No, why nerve? Is it a nerve bundle or nerve bundle or a vessel?
Sir, this is vessel, and just above it, there is a nerve, sir.
So this is actually, if you think, the extension of the same vessel. It's a thick. This vessel is continuing here. It is tangentially cut. Can you see the lumen?
Yeah.
Here, it's a
Yes, sir.
tangentially cut vessel. And where are these granulomas are located?
Sir, perivascular, sir.
What structure is this? Can you see my pointer here? Again, there is.
Sir, yes, sir.
It is also a blood vessel.
Yes, sir.
See the granulomas where they are located?
Sir, perivascular, sir.
Perivascular location. So predominantly the granulomas are perivascular or vascular location. And what are you seeing in the center of this here?
Sir, I thought it to be a sir, calcified or punctured necrosis, sir.
Thing is, in H&D, whenever you have a calcific deposition, that will be bluish in color.
Yes, sir.
Either amorphous, nodular, bluish in color. Unless until you see that, don't comment that it is a calcification. Right? Identification of calcification, is it helpful for you to give a definitive diagnosis in this case?
Sorry, sir.
Identification of calcification or observing calcification in these granulomas, will
Yes.
it be of help to give a definitive diagnosis?
Yes, sir.
What? If you see calcification, what do you think? If you don't see calcification, what do you think? See, identification, sir has already mentioned this. Schaumann bodies or asteroid bodies, although they are present, Schaumann bodies are lamellated calcification. It will not be of helpful in identifying or giving any definitive diagnosis. They can be seen in n number of cases. So for resident, all of you should remember, whenever there is a degeneration of any etiology, any infectious diseases of chronic long duration infectious diseases where there is necrosis, collagen degeneration, they are intended to have calcium deposition, right? So identification of calcification is not helpful to give or come to a definitive conclusion.
Okay.
That all of you should remember. I'll go to next slide. 1 second. Okay. Describe where these granulomas are located.
Sir,
These are
very
these are interalveolar septae. You know, here septae, one alveolar lying here. This is the interstitium, one more alveoli, and again there is one granuloma here. So these granulomas are located in the interstitium, alveolar interstitium, right? By looking at it, see there is one more granuloma here, and there is no necrosis. So whenever you see granuloma, one thing all of you should remember, and you have to include in your report, is whether there is in developing countries like India, granuloma, if you are describing, mention whether the necrosis is there or not. It is an important negative findings. You have to include this in your report, right? So what do you think by looking at all the observation on this, what you want to do next? Yes, you found granuloma. There are multiple granulomas. Some things are discrete. Some of them are, you said, becoming like confluent. No necrosis. What do you think, and what you will, how will you go about in this kind of cases?
Sir, I think it's a case of sarcoidosis, sir.
You will give a definitive diagnosis of sarcoidosis.
Sir, with multi-system involvement and sir.
So what you will do next in this case?
Sir, if we can do a sir, there are various sir CD4 to CD8 counts. The ratio of can help in diagnosing sarcoidosis, sir.
In ball fluid?
In ball fluid, sir, yes, sir.
Okay. In this case, what you will do? You have a biopsy slide with you.
Sir, we can stain it with serum amyloid A, sir.
Why?
Sir, it is used in diagnosing sarcoidosis, sir, specifically, and we can.
No. See, whenever you have a granuloma, first thing you have to do is to exclude all the possibility of infectious diseases.
Sir, Zidane staining, sir.
Do Zidane staining.
And sir, pass.
You will do fungal exclusion.
Yes, sir, GMS and pass, sir.
You will do. Then anything else to confirm that these granulomas are of sarcoidal origin? Also, it is part of diagnostic of health. Yes, Gokul?
The reticulin stain, reticulin rich.
Yes, important one thing is reticulin. What do you expect in this patient? In this
reticulin rich granulomas are usually autoimmune type of sarcoidosis, and reticulin deficient are mostly necrotizing granulomas in TBs.
Do you see reticulin rich granulomas in tuberculosis?
We can see.
You can see. You know, the initial stage of the granuloma, there is no necrosis. So these are just an additional features. And so why I'm highlighting this is in these granulomas disease, especially in lung, is one, although you will see granuloma every day, the classical cases what we describe or what you study in the book is just a tip of an iceberg. Okay, most of the things you will not see the classical cases of tuberculosis, a classical case of sarcoidosis. So you have to have a multidisciplinary approach. Call the resident. You will learn yourself. Get the history. Talk to him about the clinical findings. Talk to him about what all diagnosis they have done, what all investigations they have done. So you can give a good diagnosis. So this has to develop each and every resident at your institute. To resident discussion should develop, right? So one thing, and identifying granuloma is not only thing, the distribution of granuloma, where they are located. This is very important for you to give a typical clues along with the history. So history I mentioned, this patient had a skin lesion and this patient had blurring of the vision, and on lung biopsy you have a discrete multiple non-necrotizing lymphocyte poor granulomas with peripheral lamellated type of fibrosis. Okay, so this after discussion with a clinician, ophthalmologist here, and the dermatologist with the pulmonologist, you can come to a conclusion that it is a case of sarcoidosis. So why I'm telling you, highlighting here is multidisciplinary approach. All of you should, although you think that the case is very simple, but the diagnosis can change if you have a proper multidisciplinary approach, right? So
Yeah.
you have to
Arjun,
develop. Yes, sir.
no.
Can I add
I
something?
just wanted to tell, you see, the first two cases we discussed was just a general thing, Now it is organ specific, most of them. So you have to identify the organ, the stepwise method. Identify the organ, identify the location of granuloma, and how it is going about. And what he said was, invariably you have to do a clinico-pathological correlation. They may do a serum ACE level, the HRCT findings would have been specific, and so on and so forth. There are several things. Ma'am will, I'm sure, add to all the clinical things.
Yeah.
So that is how we
Yes, ma'am.
shoot it. Yes, ma'am. You
Okay.
want to
Yes.
show
Yeah, I
some?
have a case of sarcoidosis and CT scan. You want me to show now?
Yes, you can show it, ma'am. I'll just
Please,
stop.
and then he'll talk about some of the other differentials.
Yes,
Yeah,
yes.
so yes, this is a very important point I want to bring about. First, let me show the case and then I will
Yes,
tell.
ma'am.
So 35-year-old male, history of malaise, occasional fever, dry cough, and dyspnea on exertion, which was progressing. He had skin lesion, which was suggestive of erythema nodosa. So we did his CT scan, and you can see here in the CT scan, you are seeing multiple random nodules and the distribution, some of the periphyseal nodules, which is quite classical of sarcoidosis. And you are seeing multiple reticular opacities here, the septal thickening you are seeing, and randomly distributed nodules. You can see here. And also here the hilar lymph nodes are enlarged. You can see these are the hilar nodes. And yeah, this is a mediastinal window. You can see here, this is a big subcarinal node. This is a hilar node. So classically, compared to tuberculosis and sarcoidosis, you will have nodes which are more, extensive involvement, along with these kind of parenchymal nodules and absence of necrosis. But again, this is not always there. Sometimes, growing nodes can show area which is on CT scan appears like a necrosis. Histopathologically, you may be able to differentiate, but radiologically, that necrosis may not be, you may not be able to differentiate. And we did the bronchoscopy in this patient. And here we combined bronchoscopy with EBUS, which is endobronchial ultrasound. And even the endobronchial mucosa had typical appearance of sarcoid, involvement. So we did biopsy from the endobronchial tissue. We did biopsy from the transbronchial tissue, transbronchial lung biopsy. And we did EBUS lymph node sampling also. And all three things did show us non-necrotizing granuloma. But here I would like to say that even for a pathologist to confidently say that this tuberculosis can be ruled out, it's very difficult. Sometimes in early stages of TB, we may get nodules, which we get granuloma, which may not be necrotizing. So we always have to wait for the culture report to come. So I had a case which was sent to me by a cardiologist. She had cardiomyopathy, which was quite suggestive of sarcoid cardiomyopathy. She was a diabetic. uncontrolled diabetes, she had a cervical node, and the biopsy was done. This biopsy was very confidently reported by the pathologist as a non-necrotizing granuloma suggestive of sarcoid. But I was not very comfortable because there was some history of weight loss, and in diabetic, sometimes we may not get classical fever. Mantoux was done when Mantoux was positive. So I was not very confident of starting this patient on steroid. So I started steroid along with anti-tuberculous treatment, awaiting the culture report. And after 6 weeks, the culture came positive. And on that culture, we showed that this was a drug-resistant TB. So had I been, had the clinician or pathologist been very confident of sarcoidosis as a diagnosis and put this patient just on steroid without anti-TB treatment, it would have been disaster. So this is very important. And also very common, not very uncommonly, we see tuberculosis and sarcoid existing together. Well, one of the theories is sarcoid being a cell where antigen could be tuberculous antigen. So we see coexistence of tuberculosis and sarcoidosis also. So this has to be when you are reporting a patient of sarcoid-looking granuloma. So interacting with your clinicians is very, very important in this situation.
Ma'am, I'll just
this is
okay.
An important point that can I mention?
Yeah, and here again we additional information that we got on transbronchial biopsy that there was evidence of fibrosis and architectural distortion also. So this gives me additional info that sarcoid is progressive and is already gone into fibrotic state.
One important question can I ask and have an opinion?
Yeah.
How many times in sarcoid, the peripheral pleural space, they have a reticular shadows, and then the biopsy from the open biopsy is done, as Dr. Sudhir was showing the sarcoid. Because sarcoid, what we have read it is conventionally paratracheal, para-aortic, large, big nodes, and then have some major bronchus, some reticular shadows dot. So can you highlight the importance of classical presentation of the sarcoid from the chest X-ray CT point, and then the multiple shadows to this, where the subpleural biopsies are going to yield? Because main site of biopsies are the EBUS or maybe the FNA or whatever from that. That's what I remember. So please, if you clarify those points, that are the very important point for the pathologist to all the time think about. Yes, Dr. Dalal. Oh, you're muted, I think.
Yeah.
Yes,
so you were saying pleural biopsy?
Yeah.
So how often do we do pleural biopsy in sarcoid?
Speaking about sarcoid, yes.
Yes. So actually, pleural effusion and pleural involvement is not so common in sarcoidosis, we say. Few cases we have seen which, patient with diagnosed sarcoidosis or patient presenting with pleural effusion, recurrent pleural effusion, and all our tests for gene expert AFB culture all come negative. And then we do pleural thoracoscopic pleural biopsy. We find granulomas. But sarcoidosis presenting with pleural effusion in our practice is much less common.
When you come across with a classical case of pulmonary sarcoidosis with serum ACE levels elevated, calcium level elevated, ADA is, in case if the ADA is less and Mantoux is negative, do you still go for biopsy?
Yes, see, in case of sarcoid, we would always like to confirm the diagnosis and send a tissue for cultures. Because because there are such close mimics, both the thing. I remember one of our teachers many years back used to tell us that sarcoid and tuberculosis is like that old movie Sita and Geeta. They look so alike, including the system that they affect, that we would not like to treat these patients without confirming the diagnosis. And all the tests, the diagnostic yield for sarcoidosis is pretty high, even in a bronchoscopy, transbronchial biopsy, or even lymph node biopsy. So we would like to usually go for the tissue confirmation, and because ACE level again can be non-specific. We see ACE level being high in tuberculosis cases. Sometimes ADA levels coming low in pleural effusion. So all these are not very specific findings, and we would like to always confirm with a histopathology and culture.
This is just a message for the residents. So whenever the clinician thinks that it is a case of pulmonary tuberculosis, as pulmonary sarcoidosis, the what biopsies you will receive here is bronchial biopsy. You have to see the submucosal location of these non-caseating granulomas. One thing. In addition, you will have transbronchial lung biopsy where you will see tiny granulomas, as sir said, arranged along the lymphovascular location. Okay, so these are the two biopsies. And in addition, if the patient is having a mediastinal lymphadenopathy, you do get EBUS FNAC specimen also just to get the non-necrotizing granulomas. So these are the three important specimens we do get in sarcoidosis. In case cytology, you may get a ball fluid analysis also. So that is for the residents.
The residents must understand that the treatment is too different.
Yes.
Between tuberculosis and sarcoidosis, and lot of things are at stake. So therefore, you have to try to, as Sudhir said initially, narrow down the and come to a as close a diagnosis as possible and help the clinician.
Absolutely.
With this, can you see my slides?
Yes.
Yes. Okay. So as
before we go to add, there is some request to Dr.
Yes, sir.
Dr. Gupta. Where the 6 more cases are there, we have to be a bit fast. So
okay, we'll go faster.
please.
So these are the classic
8:45.
So these are the
So there's one thing. 2 people have said, why not it is Wegener's? You know, it's you can tell them. Actually, Wegener's, no, there'll be a lot more neutrophils. The necrosis is little more bluish. You will not get like this very commonly, like in sarcoid. Very rarely it looks like this. So,
and these are located on the periphery of the vessel, not destroying the vessels. That is to say, it is vasculitis. The inflammation should destroy the vessel wall.
And plus, you will get fibrinoid necrosis, neutrophils, and other things which are there.
Even in sarcoidosis, you may see lymphocytic vasculitis also occasionally, but the necrosis of the vessel wall you will not see. So these are the reticulin-rich granulomas. That I already said. We'll go ahead. In contrary, if you have tuberculosis, they are reticulin-poor granulomas, right? So if you see, there are few cases. See, this patient, middle-aged male, presented with this tiny papules, on just behind the ear, even on the forehead. The biopsy has been taken from this, and it shows this multiple, discrete, well-formed, non-necrotizing epithelial cell granulomas. All of them are reticulin-rich. Okay, so when you see this kind of granuloma with the fibrosis at the periphery, naked granuloma, so it is a case of cutaneous sarcoidosis. Even 1/3 to 1/4 of pulmonary sarcoid patient, they may have cutaneous lesions. So this is asteroid bodies, Schaumann bodies. This is not specific. If you identify, it's well and good. Okay, sir, can we go up because we have to finish? Shall we? You are mute, sir.
Quickly show this. Just
okay. So why I'm highlighting here is the approach to this granuloma should be very diligent. It's not like as we think. The distribution and excluding all the possible causes, etiology of the granuloma is important. See, this patient, he presented with recurrent onsets of mucosal edema from past 1 year. It's on and off. Biopsy has been taken in this from the lip. If you see that there are multiple granulomas, one granuloma here, tiny granuloma here, lot of chronic inflammation, and even the inflammation is going deep, and this is the perioral musculature, skeletal muscles, and there is a non-necrotizing granuloma. So in this kind of, when you have a clinical picture along with the other support investigations, this will falls into orofacial granulomatosis. It is not tuberculosis or it is not sarcoidosis. So that's why the importance of multidisciplinary approach in these granulomas are very, very important. Okay. Again, I will not show this. I'll show this. Can anyone describe fast? What are you seeing in this? Agar, see, again, there are, yeah, I'll just inform. See, there are tiny, as sir said, ill-formed granuloma, they are there. It is a granulomatous inflammation, and there is dense lymphocyte cuffing around the granulomas. No necrosis. Now see what granulomas, where they are located, what they're causing in the skin. They are destroying the erector pili muscles. They are present in the periadnexal locations. Okay, so when you have this kind of appearance, you are always think without any doubt, you should think of that it is we are dealing with leprosy. Okay, so when you see this patient, this is the patient who presented with the annular rash with hypopigmented area, and the clinical diagnosis was BT Hansen's. Again, it is a granuloma, non-necrotizing granuloma, but see what is causing its location: perivascular location, neurovascular bundle location, destruction of the erector pili muscle. That will be of help for us to diagnose it as leprosy. Always you will do modified AFP in these stains. You see these granulomas, they are causing destruction of the erector pili muscles. See this granuloma causing damage to the erector pili muscles. Whenever you see like this, you think that I'm dealing with leprosy. Again, there is one more case. Here it is a nerve fragment, whole nerve. There is dense inflammation. Again, you are seeing granuloma in the nerve. This patient came with pure neuritic Hansen's. Nerve biopsy was done. Neural inflammation with the granuloma. Again, it is the feature of leprosy. So you should know the location of these granulomas. Important. This I will skip. This is a single tiny subcutaneous nodule. It is excised, and the sets like spindle cell granuloma like lesions. Whenever you have this with interspersed foamy histiocyte, just do AFB stains, and you will see this globi of acid fast bacilli with high bacillary index. So it is a histioid leprosy. Importance of these are infectious granulomas, and see this patient had a big plaque on his forearm, and there is necrobiosis in the center. Biopsy has taken. See this again, it is a granuloma. Can anyone describe this fast? Any resident? What is happening? Where it is located? Which structure is this? Agar?
Gokul.
Gokul?
The granulomas are located in the subcutaneous region.
Yes.
There is clear.
See, there is a very big granuloma, right?
Granuloma,
very big
yeah.
granuloma. What is there in the center? There is wavy structures in the center. There is no caseous necrosis. There is some gap here and lymphocytic infiltration this here. By looking at this, what do you think? There is no necrosis. All histiocytes. There are giant cells, and I'll see. Let me go to the next slide. If you see that these giant cells, they're causing collagen fragmentation. Even if you see, if you do empty stain, some of the giant cells, they show collagen fragments in their cytoplasm. So what does that indicate? The thing is, if you call this as tuberculosis, or if you call this as leprosy, just by looking at the granuloma, I know only few granuloma, you can think about the treatment. 6 months to 1 year treatment the patient will be receiving. All those are toxic drugs, hepatotoxic drugs. So diagnosis is very, very important. So sir mentioned there are two things. One is infectious granulomas and non-infectious granuloma. Do you call it as infectious granulomas?
No, this is non-infectious granuloma.
Why do you think so?
There is no lymphocytic reaction.
It is there here. So whenever you see, sir also mentioned about two granulomas, blue granulomas and red granulomas. Red granulomas usually seen in necrotic infectious granulomas where you have caseous necrosis in the center. Along with that, few cases of red granulomas, non-infectious, they show collagen degeneration. Here there is a collagen degeneration. Whenever you see this kind of picture, always try to carry out the Alcian blue plus stain. You have to demonstrate the presence of mucin. That's why they're called as blue granuloma. Even in HND, the mucin, you can see that there is a bluish hue in the center of these granulomas. That can be demonstrated very well by doing special stains, AB pass. So hence, are you agree that it is a blue granuloma? Right. So if you know the clinical history of this patient, if you know the clinical appearance of the lesion, your diagnosis is very simple without any doubt. It is a case of granuloma annulare. Right? So that's why the multidisciplinary approach and is very important. This is again one more case. Can you see Gokul? Same thing. There is lot of collagen. These are all wavy collagen bundles which are fragmented. There is bluish material, as sir said, is here. This whole area is totally necrotic and collagen degeneration, and there is palisaded histiocytic arrangement surrounding this collagen degeneration. What do you think?
Rheumatoid palisade appearance is rheumatoid.
Rheumatoid nodule. So this is how you should approach. See this, even in the center, this collagen degeneration, necrobiotic degeneration, collagen degeneration, and here you have palisaded epithelial histiocyte, foamy histiocytes. Even you see multinucleated giant cells. If the patient is having a joint pain with increased RA factor, no need to think of anything. You know, that's what it makes the treatment and diagnosis very simple. If you just call up your resident and ask about the clinical history of the patient. All of you, I request all of you resident from the first year, make a habit of calling. That's what we learned from Dr. Siddharth Dattagupta sir. Call up the clinicians, resident clinician. You will develop the bond. You will learn many clinical scenario of the disease. So please develop this habit in all this thing. Again, if you see this, the clinical presentation is that small, tiny papules on the skin. Biopsy has been taken, and it shows granuloma located in the papillary dermis. Have any? If you say this has tuberculosis or leprosy, clinicians will not send any sample to you from next day onwards. The clinician dermatologist, the classical presentation is lichen nitidus. Lichen nitidus, you know, this is non-infectious granulomas. They know it is lichen nitidus. And for pathology, if you know the clinical picture, presence of granuloma, whether well-formed or ill-formed, are tiny histiocytic collections in the tip of the dermal papillae without giant cells, you can call it as lichen nitidus, and your diagnosis will be final. So you know the importance of clinico-pathological information, right? And can you see what is this? Agam, explain.
Sir, so there is a lot of foamy histiocytes are present in the subepidermal and in the papillary dermis, sir.
Yes, this is the papillary dermis, and this we call it as a reticular dermis. Can you see lobules, diffuse pandermal infiltration of foamy histiocytes? Can you see the central located nucleus and their foamy histiocytes? And if you search for it, you will find these kind of cells. What are these cells? Sir said nucleus in the center, and there is vacillation at the periphery.
Proton.
These are proton giant
Proton giant cells.
Your diagnosis will be
Xanthogranuloma.
yes. Now you know the importance of accompanying cells, the location of the granuloma, and their clinical appearance. Clinical features are very much important in each and every case. Although you think that it is simple, but when you have a clinical picture, your diagnosis can change. Right? Next, we'll go to case number 4. I think sir will take this. Sir.
Okay.
Read anyone who is
Just
A 39-year-old male presented with complaints of chronic
s-
diarrhea.
So I'll stop sharing, sir.
okay, stop.
Okay, I'll stop sharing.
You stop.
Yes.
See?
Yes, sir.
Yes, yes, sir.
Huh?
Yes, it's clean. Yes.
It's there, no?
Fourth case number 4.
Okay. Yeah. Who's taking the case?
May I take?
Huh? Hello?
Gokul.
A
Gokul.
39-year-old
It's
a 39-year-old male presented
yeah.
with complaints of chronic diarrhea, fatigue, abdominal pain, and blood in stools. Recently developed mouth ulcers, colonic biopsy for interpretation.
Yeah. Anything you feel clinically?
Sir, clinically, it is looking like inflammatory bowel disease
Okay.
or non-specific colitis, and
Okay.
also recently developed mouth
Okay.
ulcers, and also that it's pointing towards
Okay.
deficiency of vitamin deficiency.
Right. We'll go to the next case. Yeah. What are you finding?
So section shows colonic biopsy ditch. Here the crypts are more or less preserved. The architecture is preserved in the initial sections. And in that third section, we can see there is in towards deeper tissue, there is some necrosis kind of changes are happening.
Okay. And in this tissue, if you see one thing,
So,
here there's necrosis, here there's hardly any inflammation, no?
yeah. Mm.
Okay, there might be other ones. Here there's inflammation more, here it is less. Okay.
Mm.
Now we'll go to the next one. Yeah.
In this section also, crypt architecture is preserved, but in between the crypts we can see some eosinophilic infiltrates.
Yes,
and inflammatory infiltrates also. And in the third section, we can see discrete ill-defined granulomas with Langhans kind types of giant cells, epithelioid cells.
Okay. And these areas? This one?
Lymphoplasmatic infiltrates.
This is necrotic and all. It might be from an ulcerated area, no? This might be from an ulcerated area. And here, of course, is the higher power of what you had described, the granulomas and other things. Okay. Yeah, these you see, there's very small granulomas, isn't it?
Granuloma. Yes, sir.
This is the better one, which is the larger one with the giant cell.
Granuloma.
Yes, okay. So, what is your diagnosis? Any differential?
Diagnosis, I would like to say call it as a granulomatous colitis. And my main differential is Crohn's disease and abdominal tuberculosis, intestinal tuberculosis. And I would like to do AFB screen in that section to demonstrate AFB acid fast bacilli.
Okay. You know, I say one of the most important things, Gokul, is that for all of you, you know, when you do biopsy, histological evaluation for IBD, so what is the most important thing is, first of all, you must tell your clinician to send in different containers biopsies from different regions. No, rectal biopsy, then sigmoid colon, descending colon, transverse colon, ascending colon, and cecum, and they may do the ileum. You have to examine each of these regions separately because histologically and endoscopically they may be different. If the inflammation, if all the biopsies from the rectum onwards going proximally are showing inflammation, it's likely to be ulcerative colitis. If it is patchy, it is likely to be Crohn's or tuberculosis. Okay, so this is very important. And in our country, you have to exclude that. So that is one thing you have to ask. I want to see biopsies from other areas, or these are the only ones. Okay. So, and of course, for Crohn's, everybody agrees if you see a granuloma, you are more likely to be right. But the problem is, just like in sarcoidosis for pulmonologists in our country, for gastroenterologists, the problem is differential diagnosis of tuberculosis. Both of them look almost alike. So that is one very important thing. Please remember, if you have tangentially cut strips, they may look like a small granuloma. But you see, but you'll find the nuclei are similar to these nuclei, right? And if you do a mucin stain, you'll find mucin. So you must be very careful. This is not a granuloma. Then granulomas associated, if the crypt is destroyed, you see, there'll be mucin excavation and all that. So there might be a granulomatous inflammation. That is not counted as a Crohn's granuloma. The other thing is, if the granulomas are large and confluent, see, this is a confluent granuloma. So then it is more likely to be tuberculosis. If there is necrosis, more likely to be tuberculosis. If the lymph nodes are involved, more likely to be tuberculosis. There is a large small submucosal granuloma. This you can get also in Crohn's disease. See, small ones trying to become confluent. Okay, these are small granulomas. So what is a small granuloma? A small granuloma is a granuloma less than 2 crypts in width. For example, if a granuloma is smaller than these two combined, if it is so small, then it is a small granuloma or a microgranuloma. If it is larger than this, it's a big granuloma. Bigger granulomas are more likely in TB, smaller granulomas more likely in Crohn's. People have counted the number of epithelioid cells. They say it's, if it is more than 25 epithelioid cells or more than 200 micron, then it is a large granuloma. Okay, so microgranulomas are more common. So typically they are little loose, not as tight as sarcoid, non-necrotizing, non-confluent. Okay, so more number of sections you take, more likely to find granulomas. Okay, these has been studied. More biopsies, more sections, you're likely to find. Others you'll call it ulcerative colitis or some other thing. If the inflammation is discontinuous, see two different fragments, no inflammation, inflammation, more likely to be Crohn's. So when you use the term focal increase in inflammation, it means normal background cellularity with little increase in these inflammatory cells. Patchy means increased background cellularity with focal small areas of increase in inflammatory cells. So this is focal inflammation, typical of Crohn's. See, background cellularity is normal with increase. This you get in Crohn's. This is patchy inflammation. You can get in a lot of conditions. Full background cellularity increase with this. Okay. More than 2 lymphoid follicles, if you are finding per millimeter of biopsy, it is abnormal. Submucosal inflammation, more likely to be Crohn's or TB than ulcerative colitis. So what is an aphthous ulcer? Anyone? Quick. What? Which is an aphthous ulcer? Okay. See, the word aphthous means set on fire or to inflame. And Hippocrates described it mainly for mouth ulcers. Okay. In colon for Crohn's disease and all, aphthous ulcer is ulceration over a lymphoid follicle. That is what is an aphthous ulcer. Then you get cryptitis, cryptapsis, and so on. At least two features, small granulomas discontinuous architectural abnormalities, and discontinuous inflammation, and focal cryptitis. If you get any two, more likely to be Crohn's. Inflammation near ileocecal region, more likely to be TB. Inflammation away from ileocecal region, more likely to be Crohn's. AFB is absent. TB, unfortunately, you can get AFB positive in only 5% of cases. But large granulomas, more likely to be TB. So this is a study, and all of them are similar wherever we have studied. So caseation necrosis, more sensitive for TB. Confluent granulomas, more sensitive for TB. Ulcers lined by epithelial cells, more sensitive for TB. Okay. They can do AFB and other things. The AFB positivity in TB varies from 2% to 30%. Culture positivity is more, it can be as high as 50%. Then of course you can do the PCR and other things. So you have to compare the endoscopic histological features. If both are typical, then you can treat as Crohn's or TB. One is typical, one is suggestive, then clinician takes a call. But if the changes are not typical, then a follow-up is done. Phase 5. Yes.
Can I say something, sir?
Yes, yes, please.
One important point is when the patient of ulcerative colitis is on treatment and he is responding to a very good extent, then the inflammation, everything is down and he is recovering with the near maintenance of architectural pattern. And along that, if there is a crypt granuloma, associated granuloma, that's nothing to differentiate from the Crohn's. So how you will approach that point is probably you need.
Yeah.
It is very good. Yeah.
You see, if it is a known case of ulcerative colitis, then of course you have to take the other features into account. But for the first time if he comes, then it becomes difficult. Then you have to see whether the inflammation is continuous, starting from the rectum, or it is patchy and so on and so forth. Then only. But mistakes have been done. One has been treated for the other, and later on only, when the disease progresses, the clinician and the pathologist will sit together and find out that this is.
Yes. Thank you, sir. Because crypt-associated granulomas are many times are in ulcerative colitis, and that is the biggest problem of that. Yes, very nice, sir.
Okay. Sudhir?
Yes, sir. Next, who is going to take case number 5?
I think,
Please be quick.
the lady is there now? Pratish?
Yes, sir.
Yes.
21-year-old male with sudden history of death. The sections from the lung were taken for interpretation.
Sudhir,
Sir,
have you shared your screen?
yes, I shared my screen, sir. Can you see, sir?
Okay, okay. Yeah.
Yes, sir, visible.
Yeah, visible.
Yes, a young male.
21-year-old male with sudden death history. The sections were taken from the lung for interpretation.
Why this 21-year-old healthy male will have sudden death? Can we expect what would be the reason? So if you think there are many reasons, yes, anything, either cardiovascular sudden death is most common, cardiovascular etiology. Let's see, we have taken multiple sections from all the organs. This organ showed classical histopathological features that made us to think and take further history, right? Observe which organ is this?
This is a section of lung.
Why do you say it is lung? Fast.
So we can see the alveoli here and the bronchial epithelium.
Yes, so this is very classical alveoli, and there is a bronchus here, bronchus bronchiole, and bronchial associated blood vessels. Fine. Next, your observation.
So I can see 2 granulomas here, the second section.
Okay, 1 and 2. Where are they located?
So located between the alveoli.
You mean to say somewhere in the alveolar interstitium?
Yeah, interstitial, sir.
Can you make out necrosis or not at this magnification?
Sorry, sir.
Are you able to identify necrosis or not?
No, sir.
No. We'll go to next slide.
Yes, Sudhir,
Sir.
you know, many people have asked, how do you differentiate interstitial granulomas from intraalveolar ones?
Intraalveolar. So, interstitial granulomas means the granulomas present in the alveolar interstitium. So, see this is the interalveolar septate, right? All of you can see there is one alveolar here, one alveolar here. If you find granuloma here, okay, this is called interstitial granuloma, interalveolar granuloma. Intraalveolar granuloma means you will see granuloma within the alveolar lumen. Understand? So just like a hot tub lung disease, all those things you'll see intraalveolar granuloma. And interstitial granuloma within the alveolar interstitium, this place most commonly because it is the space where you have lymphovascular structures. Sarcoidosis will be the main differentials. Understood? Okay. Yes. I'll go to next slide. Identify. And let's see your observation. So why I'm highlighting is granuloma component, structure, and their location is very important. Right. Again, there are seeing, yes.
Sir, I can see granuloma.
Correct. Here one
Sir,
granuloma.
yes, sir.
Okay. There are again granuloma. What structure is this in the fourth picture? Columnar epithelium.
Yes, sir, columnar epithelium. So this is the bronchus.
Yes. And where are the granulomas are located? On either side of the bronchus. It is causing compression on the bronchus. Agree?
Yes.
Okay. So are there any peripheral demarcation in these granulomas?
Yes, sir. There is fibrosis.
Yes.
I mean, fibroblast are there.
Let's see. Let's go to other sections. Okay. Can you still make out where exactly the granulomas are located?
Yes, sir.
Yes. Where? See the third picture. What are these structures?
Are these any secretions?
Some kind of a foreign material.
Foreign material, yes.
Foreign material that is eliciting granulomatous inflammation.
Yes,
Observe any doubt till now? Where this granuloma located? Third one, and even if you see the fourth granuloma. What structure is this?
Fourth one is, please see carefully.
Yeah, see carefully. I'll just highlight the structure. So I'll just trace. Can you see my arrow? See this? What structure is this? Which has got smooth muscle in their wall. Again, there is.
So this.
Yes. What is this?
Someone has said that the slides are not moving. Please see whether.
One second. Slides are not moving?
Not moving.
No. Can you see these four pictures?
Four pictures are there. Yeah.
Yes, sir. Yes, sir. So this is the arrow. So just see what structure is this, which has got smooth muscle in their wall and contains the RBCs in their lumen.
Blood vessels.
Blood vessels. These majority of these granulomas, they are present within the blood vessel lumen, causing luminal occlusion. Agree?
Yes, sir.
So what can you think? In 21-year-old male presented with multiple granulomas, presented within the vessels, some of them are in the interstitial location, they have a foreign material, some structures that is eliciting granulomatous inflammation.
Can it be pulmonary embolism?
Pulmonary embolism. Let's see. Again, there are many vessels that I am highlighting here. Can you see? You can make out some part of the vessel wall and adjacent lung parenchyma showing what? What is this eosinophilic structure accumulated in the alveolar lumen?
Pulmonary edema.
Yes, pulmonary edema. Pulmonary hemorrhage. Pulmonary edema. Associated pulmonary hemorrhage and edema. Right? Yes. And even if you see under high power, there are some polarizable crystalline like material in these giants. What is this? Why they are located within the
IV drug abuse.
Yes. So
Very good.
this very good, excellent. Who told? Who
Gokul, I
mentioned?
think.
Gokul, excellent. So whenever you observe these kind of granulomas predominantly leading into vascular emboli, giant cell reaction, vague granulomatous inflammation associated with pulmonary edema. So in this patient, I'll tell you, each and every slide and almost 95% of the blood vessels were occluded by this granulomatous reaction. When we asked the history, he was a heavy drug abuser, and recently he mixed many drugs, many powdered drugs, and some of them are oil based, some of them are water dissolvable. He mixed in water, he injected in the vein. So this is all because of this IV drug abuser. You should always think the history will solve your problem, right? IV drug.
Sometimes, no, the IV drug abusers, talc is very common. Talc,
Yes.
they mix with this one. There's a bluish material sometimes you get. There are some of the other excipients which are, put solvents which are added with the drugs. There are some polyvinyl chlorides and other things which are there. Sometimes you get that. But this picture is almost typical. You'll invariably polarize and you'll find sometimes.
Yes, sir. See this? All the blood vessels are flooded with this foreign body granulomatous reaction. Is there any differential diagnosis? If you don't ask history, you will have many differential diagnoses. If the history is straight, he is a heavy intravenous drug abuser. Is there any differential diagnosis in this case?
Okay.
No. As sir said, polarizable material, if you can do polarized microscopy, you can try to identify the polarizable material. So he was an extensive pulmonary vascular emboli with foreign body granulomatous inflammation with associated pulmonary edema and even pulmonary hemorrhage. Okay. Case number 6 will
Sir,
take.
sir, this cannot be possible with only one bout of.
No, he was heavy, long-term addicted intravenous abuser.
Yes,
It's
thank you.
not one bout. Yes. So even for giant cells of foreign body to generate, granuloma, it
2
needs
weeks.
to have at least 1 to 2 months to develop granuloma, giant cell reaction. So it was a chronic case. Next, who will take case number 6 first? Those who have not taken, you can
I
just
think
read.
everybody is taken one, no? Everybody is taken one, each one.
Yes.
Each one. Case number 6 was allotted to whom?
Nobody's been allotted. Everybody
Okay.
is in. Sudhir, I
Sir.
think you can describe one by one because time
Yeah,
is
time
to
is
be
less.
served.
Well, see. Okay. Case number 6. Middle-aged male presented with a history of gradual onset of shortness of breath, tiredness, and weight loss since 2 years. Symptoms gets progressively worse over time. On examination, prominent clubbing of the fingers were observed and lung sections for interpretation. The clinical history suggests that there is predominantly lung involvement. Hence, the lung biopsy they have taken.
Acha, all of you have taken at least one case, no?
Yes, sir.
Yes, sir.
Okay. If you are interested, you are most welcome.
Yes, if anyone wants to describe the findings, that's more than sufficient. Anyone volunteer to describe the findings?
Sir, it looks like, sir.
Yes, very good. Section from lung. Yes, because there is bronchus here, associated vessels here, and the normal lung parenchyma, which we saw in previous cases. Can you make out the alveoli?
No, completely fibrotic lung.
Yes, that means alveoli, there is this severe destruction of the lung parenchyma. The alveoli, the normal alveolar structures are already distorted, and somewhere you will see some emphysematous changes, lot of fibrosis and distortion of the normal alveolar structures. Right? Agree with me? Why there is destruction? The cause of destruction is a lot of fibrosis.
Fibrosis.
There is fibrosis, there is patchy chronic inflammation. Somewhere it is located in the peribronchial location. These are all pigment, anthracotic pigment deposition. And see this, there is a distance between this alveoli and this alveoli, they are increased. Okay. Interstitial fibrosis. So whenever you have a prominent interstitial fibrosis, it hampers the oxygen saturation. The patient will present with hypoxemia, easy tiredness, low blood oxygen level. So on the contrary, they will also have increased blood carbon dioxide levels. Okay, so that's why these patients will develop a easy fatiguability and shortness of breath, tachypnea episodes. Let's go to higher power. The same thing, even if you see the blood vessels are also thickened. So whenever you see thickened blood vessels, it is again an indirect indicator that the inflammation or inflammatory disease, what is there, it is chronic disease. It causes the thickening of the blood vessels. It can be observed in pulmonary hypertension. Okay, and there is one bronchi here, one bronchi here. So you will not expect so many bronchioles which are lying adjacent to each other in the lung. If you see the histology, right?
So, sir, why can't be this be lambatosis in a chronic disease like this?
Yes, yeah, very good observation. See this. These are actually, if you observe, some part is lined by the alveoli, but other part they are lined by respiratory epithelium. So these are the normal alveoli, which the wall is replaced by a respiratory epithelium. This we call it as lambatosis that we see in
Usual
chronic.
interstitial pneumonia.
That is one example. Any chronic infection,
Idiopathic pulmonary.
any chronic lung diseases, you may have this kind of information. These are also called as bronchiolization of the
Yes, sir.
alveoli.
Bronchial metaplasia.
Whenever you have a bronchiolization, again it interferes with oxygen saturation. That all of you should remember. Whenever the epithelium is single layered, it helps in oxygen saturation, oxygen diffusion. When the alveoli is thickened, instead of flattened, it will become columnar along with interstitial fibrosis. Both together will hamper the oxygen saturation. Right? Any doubts till now?
No, sir.
Yes. Okay. See this again, as you rightly said, there is lambatosis, there is interstitial inflammation, and there is thickened blood vessels. Peribronchial chronic inflammation. Peribronchial chronic inflammation is again important finding for the diagnosis, and the presence of a lot of fibrosis and alveolar destruction that indicates that it is a chronic lung disease. So here till now there is a chronic lung disease with peribronchial inflammation. There are the two observations they have done, and even if you see there is mucus plug formation also, that is impairing the mucus clearance. Again complications. Thick walled blood vessels. Again, can you see this? There is bronchial. This is the bronchi where there is proliferation of myofibroblasts here. That I will show you in next slides. Chronic lung disease, fibrosing, peribronchial inflammation, alveolar destructions, mucus plug accumulation within the alveoli. So whenever you have a mucus plug stagnation in the pulmonary parenchyma, these are the rich source of for a secondary bacterial infection. These patients will come for recurrent pulmonary infections, recurrent pneumonia, right? Observation. And the important thing is we are finding some kind of this granulomas either within the alveoli, some of them are present in the interstitium. Okay, and this is the alveoli showing the prominent plump alveolar lining epithelium. It is nothing but
Type 2.
hyperplasia of type 2
Type 2
pneumocytes.
pneumocytes.
So whenever you see hyperplasia of type 2 pneumocyte, that indicates that there is an alveolar injury and it is undergoing for reparative process, right? And if you see granulomas, they have cholesterol cleft in the granuloma. Can you make out the diagnosis at this magnification with these findings? See again, patchy chronic inflammation, alveolar destruction, mucus plug, thickened blood vessels, vague multinucleated giant cells. Can you see here in the interstitium and also in the interalveolar lumen with the cholesterol clefts? If you observe these things, it will be easy for you to diagnose this case.
tub lung?
No, hot tub lung, it is usually you see tiny, it will not show that much of fibrosis, hot tub lung. Very ill-formed granulomas within the alveolar lumen. It is
Aspiration pneumonia.
yes,
hypersensitivity pneumonitis.
Aspiration pneumonia.
Yes, that is a very good. What stage of hypersensitivity pneumonitis? Can you see this? Even in
Advanced stage, sir. Honeycombing is present, sir.
correct. So whenever you see alveolar destruction, lot of fibrosis, tachychronic inflammation, it is almost going towards the end stage fibrotic lung disease. So here it is good enough we identified the giant cells. If you don't identify giant cells, it is not possible for any pathologist when the disease is in the end stage, that is end stage diffuse fibrotic lung disease, it is not possible to say why the fibrosis, what is the etiology of fibrosis in this lung diseases. In this, we identified multinucleated giant cells, cholesterol clefts, and peribronchial inflammation that made us to think that it is a hypersensitivity pneumonitis. Even if you observe these cases, you do see Mason-like bodies, fibroblastic proliferation here, and there is fibroblastic proliferation here within the alveolar, pushing towards the inside the alveolar lumen. There is fibroblastic proliferation within the bronchial wall. If it is more, it occludes the bronchial lumen. Then we call it as bronchiolitis obliteraris, right? If the plug, it occludes the alveolar lumen, we call it as, we do call it as organizing pneumonia.
Organizing pneumonia.
Okay, so all these features you can see when you have a chronic hypersensitivity pneumonitis. Your diagnosis was right, and even if you see that, sometimes you see smooth muscle metaplasia also in the interstitium. That again indicates its chronicity of the lesion.
Sudhir,
Sir,
if you saw the fibrosis pushing the bronchial mucosa, no?
Yes,
If
sir.
you find granulomas pushing the
Yes.
bronchial mucosa, think of hypersensitivity
Correct.
pneumonitis. That is one feature. Yeah, this is the
Mason trichome stain, just to demonstrate the fibrosis. Can you see? There is a distance between one alveoli and another alveoli is so much. Can you think of diffusion in this patient? No. So what could be the treatment of choice in this if you see this kind of a biopsy? Are there any medical line of management?
Lung transplantation.
Only the choice is lung transplantation, and actually it is a case of lung transplantation.
See,
So
this is equivalent to cirrhosis of the lung.
yes.
You cannot do anything. It's all fibrous. There's no way the airways can. This is the excised lung of that transplant.
Excised lung, this central part is unfixed. Can you see this? There is some cystic dilated structures, nodularity, there is uninvolved lung parenchyma in between, multilobar involvement, peribronchial location, all those features. It is a case of hypersensitivity pneumonitis. He was a case of hypersensitivity pneumonitis. There's progress toward, yes.
Can we call it temporal heterogeneity in this, sir?
So if you want to call, you can call in many cases, but certain terminologies you have to be limited to a certain disease. Now, you should not use those terminologies in other diseases. When the clinical setup and radiological setup is in case of either non-specific interstitial pneumonia or idiopathic interstitial pneumonia, then it's your duty to describe either temporal heterogeneity or spatial heterogeneity. Okay, those terminologies better to keep restricted to certain diseases. Okay, although it might meaning may be the same, but you should not use in case of hypersensitivity pneumonitis. One thing again I would like to highlight is in chronic hypersensitivity pneumonitis, even you do see NSIP features, you do see focal areas of UIP features, idiopathic interstitial pneumonia, you do see bronchiolitis obliterans or organizing pneumonia, all type of patterns you may see in end-stage lung diseases? Right? That is a good question. Yes.
Can I say something about it?
Yes, yes, sir.
Yeah. How we, if only the biopsies has come and no radiological features, the importance of the localized bronchiectasis and the same changes that you are showing, is there are much more things that we can dissect it out how to differentiate.
No.
Localized bronchiectasis, because the tissue will have a same way of reaction.
Yes, yeah, definitely. So this has to be, as I told, the localized bronchiectasis, most commonly, it will have some kind of an obstructive etiology. Obstructive etiology, they do undergo, these patients, they do undergo bronchoscopic examinations, and if not possible, they will dissect that part of the lobe. So there, the predominantly the bronchioles wall shows dense inflammation with dilated, irreversible dilated mucus plugs involved. But here, the alveoli, they're also distorted predominantly. The bronchial, there is peribronchial inflammation, but bronchial walls are not showing that features of necrotizing inflammation of the wall. But on the contrary, in late diseases, they may also have bronchiectasis.
Yeah. Good.
As you can have secondary.
Yes.
So this is
Thank you.
Case number 7, I'll repeat. 42-year-old female presented with a history of headache, dizziness, weakness, pain in the upper limbs. Okay. Clinical examination revealed weak radial pulse, section from the thoracic aorta. I'll just go.
Yeah, Sudhir, you can go.
Yes, I'll just move. Okay. So can anyone describe what is this? Is the wall, aortic wall, right? I'll just tell you the findings. Let's see, if you observe, do you think the aortic wall is healthy? Gokul?
Can you repeat the question, sir?
By looking, this is the first section, it shows that it is section from the aorta wall, aortic wall.
Yes.
By looking at this, do you think the aortic wall is healthy or
No, sir.
abnormal?
Sir, it's more of fibrose, sir.
Yes, there is a lot of fibrosis. Anywhere in the body, many vessels, they will have always, if they are not involved, they will maintain the contour. Can you see this? There is irregularity in the wall. Can you see this? And there is a lot of fibrosis. There is fibrosis. If you see the second picture, can you see this is the adventitial aspect? This whole thickness is the media. And if you divide the media, this part is not showing any nucleus. Right?
Yes, sir.
Here towards the adventitia, you have smooth muscle nucleus. There is smooth muscle nuclei loss. Okay, that picture indicates there is severe smooth muscle nuclei loss. Smooth muscles are destroyed in this area. Okay, if you see the next slide, again there is the adventitia.
Sudhir, in the first one, okay, anyway, second one also
Yes,
shows.
yes. And if you see this third, can you see normally in the media, if you see the medial smooth muscle cells are very well orientated, very well oriented. They are properly arranged. The nucleus will be parallel to the lumen always. And if you see this, what is happening? Do you think the nucleus is parallel to the lumen or they are haphazardly arranged?
Haphazard, sir.
This. So whenever you see this kind of haphazardness in the vessel, we call it as
Elastomer.
smooth muscle disarray, disorganized arrangement of smooth muscles. We saw irregularity in the wall. We saw nucleus loss, smooth muscle nuclei loss. We saw smooth muscle nuclei disarray. So whenever these things happens, the wall will become weak. The normal structure of the aorta will be distorted, and because of this weak arrangement, the wall will become weak. Why the wall has become weak? If you see more sections, can you see there are some patchy chronic inflammation, right? Can you see it here?
Yes,
Where
sir.
is the inflammation located? It is in the vessel wall or outside the vessel wall?
Sir, outer part of the media, sir.
But the primary structure involved is the media.
Media. Yes, sir.
If you want to, earlier also, previously there was a question raised by the resident. Whenever the inflammation predominantly involves the vessel wall, then only you call it as vasculitis, primary or true vasculitis. If the vessel wall is involved by secondary inflammation, there is an cellulitis, adjacent vessel is involved as a process because of cellulitis, don't call it as vasculitis. You should not mention in your report also, right? So when the vessel wall is primarily involved because of inflammation, then you call it as vasculitis. Now, Agam, tell me, is it a primary inflammatory disease of the vessel wall or not? This is the entire media. There is inflammation here. There is inflammation. There is inflammation, 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 inflammation. Adventitia looks fine. Fat is looks fine. There is a true inflammation of the vessel wall. Yes or no? Any doubt? Any question, doubts, you can clarify. Inflammation is limited to the vessel media or not?
Yes, sir.
So it is a vasculitis.
Yes, sir.
Understood?
Yes.
Vasculitis. And rest of all secondary changes, what you're seeing, medial smooth muscle loss, smooth muscle disarray, areas of fibrosis, they are all can be explained because of secondary inflammation causing destruction of all these features. And
Yes.
one more important, if you see the adventitial blood vessels, no, usually it will not be that much thick. So whenever you see thick adventitial blood vessels, that indirectly states that the process is a chronic disease. Now tell me, it is an acute or chronic disease? Because I'm saying
Chronic
thick
disease.
wall blood vessels, it is a chronic disease infecting the major wall. If you see this, if you observe, there is an inflammation here, small nests of inflammation. This inflammation, they are very much close to the adventitia, but they are within the media.
Media.
Within the media, they are also there, but predominantly located in the outer 1/3 of the media, which is close to the adventitia, right? What structures do we expect at this location? Which supplies, which gives
Vasa.
vasa, vasoram. So this inflammation, if you observe, there will be small vessels inside in between this inflammation. So perivascular inflammation. And see this fourth area, the whole area is totally replaced by fibrosis and it is hyalinized. And you will see small areas of speckled dystrophic calcification as a degenerative process. If you see the observe the periphery of this collagen, you have inflammatory cells, you have granulomas, you have multinucleated giant cells, epithelioid histiocytes. Can you see at this magnification? All are there at the periphery of this degeneration. Can you see this? They are appearing as if they are preventing the process, right? They are there at the edges. I'll show you a few other pictures. Can you see this big inflammatory infiltrate towards the adventitia? There is a blood vessel here, right? Can you see this blood vessel? And see this whole entire thickness of the aorta is totally damaged. No smooth muscle cells. It's just like national highway of fibrosis, right? Only fibrosis. Here you have seen some kind of foamy cell aggregates that indicates atherosclerosis, and there is a lot of inflammation. If you see this inflammation and high power, majority of this inflammation of plasma cells. Can you see this collagen degeneration in the wall? And observe all those histiocytes and epithelioid histiocytes, they are guarding this collagen degeneration. They have come to clear up this collagen degeneration. Can you see this? All the histiocytes?
So there,
Sir?
this area, we see it looks almost like a rheumatoid nodule.
Yes, correct.
Because there's collagen degeneration with those almost cells palisading. It looks like that.
So this is
They'll
the
remember.
Yes, this is the yes, rheumatoid. You explained the similar like appearance. Collagen degeneration in the center, surrounded by histiocytes at the periphery. You may see multinucleated giant cells also, right? Now tell me, is it an infectious granuloma or non-infectious granuloma? By looking at this appearance and morphology.
Non-infectious.
Yes, it is a non-infectious granuloma. Infectious granuloma shows more of a necrosis, neutrophilic infiltration,
Separation.
so yes, separation thing. And there are a few more pictures depicting or showing predominant plasma cell infiltration, severe wall destruction, damage by fibrosis, which all together causing stenosis of the great vessel. When there is stenosis, the particular segment of the vessel, especially the major aorta is involved, what will happen to the pulse? It will not transmit the pulse, systolic pulse. It will become more of a streamline. Hence, this patient had no pulse in the radial arm. So, when you see the classification of vasculitis, where do you classify this?
So large vessel vasculitis.
These are large vessel vasculitis. What are the examples of large vessel vasculitis?
Takayasu and giant cell arteritis.
Takayasu and giant cell arteries. Both are almost same with same etiological features. Okay. There is an age criteria.
Yes, sir.
This can involve.
Sir, it's a dicey age actually.
Correct.
All the criteria for Takayasu is less than 40, and for giant cell it is more than 50. So there's 42 lies in between.
So thing is, giant cell arteritis most commonly affects the temporal artery, less commonly the major blood vessels. Takayasu more commonly affects the major blood. That you should think.
You see, many years ago, the same thing, no, vasa vasarum being infiltrated, narrowed, causing ischemia as well as this inflammation, used to be seen in syphilis. But we don't see them nowadays. So that differential is almost out now. So it is mainly two.
Yes, sir.
Okay.
The cause. Ultimately, you may have a dystrophic calcification. So you do see calcific deposits on the degenerated area. This is amorphous calcification deposition. Because it is an inflammatory process, you may have evidence of or increased atherosclerotic changes in these patients. Again, atherosclerosis is again a chronic inflammatory disease of the blood vessels, larger blood vessels. So any inflammation can also enhance the atherosclerotic process. So you may see, I also showed in previous slides, you may have subintimal atherosclerotic changes in these individuals. This is a Masson trichome stain just to demonstrate fibrosis. Can you see this?
Fibrosis.
And these are inflammatory cells. They are surrounding this fibrotic area, and you have plasma cells here. Okay. This is perhaps Van Giesen stain. Yes, elastin stain. Can you see this? Media will have, these are called elastic arteries, you know. When you do
elastophagia.
Yes, this all elastic, some of the remnant elastic fibers, they are left here. But here the total elastic tissue is totally gone, replaced by fibrosis.
In fact, aorta is an elastic artery. You know,
yes, sir.
Lot of elastic tissue. This all one.
This is elastic tissue. So all this leads to weakening of the vessel wall. So you may have aortic luminal narrowing and also aneurysmal dilatation. Okay, again, few more pictures. Can you see? This is a maintained medial elastic fibers, and the inflammation is there at the periphery. The part of the elastic structure is maintained, but here is totally lost. So even see this. This
the mucin
stain, you know, mucin deposition. It also aggravates mucin deposition. This is present of mucin in the lamella. This is one lamella. Okay, can you see this wavy nature of the elastic fiber here? One smooth muscle, and in between you have mucin deposition. This we call as intralamellar type of mucin deposition is one of the component when you are describing medial degeneration or degenerative aortopathies. Okay, that will take up some other time when we have next seminar, the aortopathies.
You know that aortopathies like Marfan's and others,
Orphan syndrome
where
and
you
all.
have lot of medial degeneration.
Degeneration.
Okay.
This mucin is basically mesenchymal mucin. So not to differentiate
Yes.
with the epithelial
Yes,
That's
mucin.
yeah, that's
So
a very
chondroitin
Yes.
sulfate, heparan sulfate, and
Yes,
those,
yes.
yeah, Hurler disease, mixopolysaccharides, and many other things that.
correct.
Yes, very good. Yes.
So this is the case of Takayasu arthritis. All of you can identify Takayasu arthritis if you get a specimen.
Yes, sir.
Yes.
So IHC is not necessary for diagnosis, but for you to understand, you may have T cells. These are B cells, CD20 positive B cells. They have CD138, predominantly plasma cells, and few dispersed B cells. And you have T cells also, CD3 positive T cells.
Is there any other name for this Takayasu arthritis?
Pulseless disease.
Pulseless disease.
What is aorta arthritis?
Aorta arthritis.
Takayasu.
Yeah.
Non-specific aorta arthritis.
Non-specific aorta.
Aorta. You have to exclude, although in tuberculosis endemic countries like India, it's our duty to exclude the possibility of tuberculosis, right? The most common cause of inflammatory aortitis
Is tuberculosis.
tuberculosis, where there is para-aortic lymph nodes. They are tubercular lymph nodes. They will undergo caseous necrosis. They'll rupture, and the inflammation spreads to the adventitia of the blood vessels, major blood vessels, causing into aneurysmal dilatation. So that is the cause, one of the important cause. All of you should know and try to exclude before you label it as non-specific aorta arthritis. Right? Last case, a young, severely immunocompromised male. I will not show this. I'll just, can anyone describe this fast?
Sir, it's a necrotizing large granuloma.
Second from left out.
Yes, it is a large necrotizing epithelial cell granuloma. You say confluent granuloma,
Yes,
right?
sir.
There are
Sir,
multiple.
complete effacement of the lymph node architecture, sir.
Excellent.
Parasitic.
Yes, entire lymph node is involved. Large areas of necrosis. What do you think?
Sir, fungal pathology.
Eh? Why not tuberculosis?
Sir, because sir, it's the
Tuberculosis is
immunocomprom.
common. No, that's what I skipped.
No.
I
See,
skipped the slide.
immunocompromised can get tuberculosis.
Tuberculosis, it's endemic countries like India. Even in
Sudhir, go
immunocompromised.
to the next power.
See this.
Higher
One
You
more
can see
power.
fungal.
Okay.
No, as you see, this looks almost not exactly caseous, somewhat coagulative, like that it looks. You see, somewhat, you can get the outline of some cells. Sometimes in fungal, especially those fungi which have a propensity for entering the blood vessels, like pheohypomycosis, some aspergillus, you can get with caseation some coagulation like necrosis. See, the ghost outline of cells are being seen. So that is another pointer. If you find neutrophils, that is another point. But good. What Sudhir said, no, you cannot rule out tuberculosis outright like that. Okay.
Even in immunocompromised, TB is again the most common thing.
Yes, sir.
But of course, if you have seen some organism, it's a
Organism,
different.
unless
Yes, sir. That's why I saw the next slide.
You can see the
what did you see in this?
fungal spores
Sir,
can be
yeast-like organisms which are marked variation in their size, sir,
Very good.
and
There was another slide, no? Next, Sudhir.
Yeah, next. You see this?
There.
Can you see this?
yeah.
yes, sir.
Structures. This
Sir,
structure. Yes.
sir, budding is present, sir,
Budding is present.
with the broad-based.
Acute angle.
Branching is present. Right? Budding is present. Branching is present. And what is this? whether these fungus
So in ingested RBC,
they have some color to it. How many fungal structures you have seen? On HND, most of the fungus they'll have eosinophilic like structures, But what are these structures? Which color are these?
Brownish.
So whenever you see brownish color in the fungi, that is called as pigmented fungus.
Pigmented fungus.
Okay.
The pigmented fungus, you have to identify, try to classify. Okay, at least pigmented and non-pigmented fungus, we can say an HND. So when you have pigmented fungus, if you see an HND, you need not have to do special stains for demonstration. Not required also, because pigment itself is very beautifully seen. You can identify the fungal hyphae. The what species is it? Only you can do by specific culture methods, right?
Okay, the two ladies, no, they are silent. See, when you find fungus, what are the things you have to look for? Let the ladies say. Rashmi and who? What are the things you have to look in a fungus?
whether there's an intracellular or
No, let the two girls talk. No, they have not even opened their mouth, other than the two cases. Yeah, Rashmi.
In which form they are, whether yeast form or hyphal form.
Correct. You have to first tell whether they are yeast-like, rounded, or hyphal form. Suppose they are yeast-like. What will you see? If they are yeast-like, one thing is you look at their size. Depending on the size, you can exclude the candidal species from the other species. Candidal species are small in size. Then you see whether there is a capsule or not, right? And then depending on that, you can find histoplasma and cryptococci, depending on that, right? If there is both yeast form as well as hyphal form together, then it's more likely to be, depending on the size, could be candida, because in that you will get like almost this, although they are pseudo. So when you find a hyphal form of fungi, you have to see whether they are broad, whether they are narrow, whether they have parallel walls, whether they have septa, and whether they are branching and at what angles. So if they are non-parallel walls, okay, and septate, they are more likely to be zygomyces or pheohyphomycosis. Then if they are parallel walls with regular septae and they're branching in a particular pattern, they're aspergilled. Then in that the others, you find whether they're pigmented or not. Okay, pigment will help you in telling what kind of fungi they are and so on. So this is basically how you go about doing a fungus. So in this case, what have you thought of? Who was describing?
Rashmi.
Or
here in this,
Prantike.
we are seeing the budding yeast forms, and also there is a
I'll show you
acute
special
branch.
things. Okay, 1 second. I'll show you special things. Okay, tell me.
Tell.
Here,
can you see
budding,
the budding?
Yes, sir. Budding yeast forms are seen, and also branching is seen. A broad base.
They are pigmented.
That we saw in HND, no?
HND only. What is your diagnosis? So for your reference sake, no, when you see a pigmented fungus, you should be able to differentiate whether it is there are two most important things. One is pheohyphomycosis chromoblastomycosis, pigmented form. Most commonly, we do see these fungus, right? Pyohyphomycosis, the pigmented fungus which show septation and branching, hyphal form, right? And chromoblastomycosis, what do you call the other name? Appearance or structure? What do you say?
Copper penny bodies.
Copper penny body. They are non-branching pigmented fungus. So if you know this at this resident level, that is sufficient. Okay. Now you'll differentiate chromoblastomycosis. No branching, no hyphae. It is, no branching, pigmented, copper penny-like structures. Pyohyphomycosis, they are pigmented, branching, septate hyphae. Right. So this case, we have severe immunodeficiency. This is a disseminated fungal infection, pyohyphomycosis. Okay, this is important because see this patient. Why I'll tell you 3-4 cases. This patient presented with big plaque on his eyelid, forehead, and skin biopsy shows a diffuse pandermal dense inflammation. From here till here, continuous diffuse inflammation. If you see under high power, predominantly lymphoplasmacytic. Can you see plasmacytic infiltration along with vague ill-formed granulomas, interspersed histiocytic aggregates? So when you see this kind of inflammation, where in skin biopsy, lymphoplasmacytic cells are very predominantly diffuse infiltration with tiny ill-formed granuloma. Always, if the patient is from UP, Bihar, or Rajasthan area, it is you have to search for LD bodies. Cutaneous leishmaniasis, right? This so accompanied cells and clinical things is also very important for your diagnosis. You have to search for LD bodies. If it is pure cutaneous leishmaniasis, I agree. Even after doing special stains, demonstrating LD bodies is very difficult. Very difficult. You may not see at all. So you need to have proper clinical and pathological correlation in these patients, right? What is this? One more skin biopsy, and what are you seeing it here? There are histiocytes, granuloma. Then what are these structures?
Fungus.
Which fungus?
Histoplasmosis.
Why do you say it is histoplasma?
Sir, small round with a clearing of the sir perinuclear it's the clearing around the yeast form, sir.
Correct. Clearing. And how do you say
similar in size?
How do you say these are small?
Sir, smaller than the lymphocytes.
Adjacent cells you should compare.
Lymphocytes.
Lymphocytes, if you compare, they are small. Where they are located? This is the histiocytic nucleus. Where they are located? This is the histiocytic nucleus where these
So in the cytoplasm, sir.
Predominantly intracellular. So your diagnosis is
histoplasma.
Histoplasma. So you have to this histoplasma. If you see, they can also have granulomatous reaction. Histiocyte. Can you see epithelial histiocytes?
Yes, sir.
The left side, yeah.
Okay. So one thing you should remember: these histoplasma, clinically, radiologically, they classically look like tuberculosis. Sometimes it is not possible to differentiate histoplasma tuberculosis. That time comes the importance of pathologists. If you identify these organisms, then the diagnosis will be solved.
Sudhir, when we were residents, one of our teachers who was from States, she used to tell that tuberculosis in Kansas City is histoplasmosis. It's almost same. They get almost similar features.
Okay, so identification is very important. Yes, sir. I agree, sir.
Next
slide. Again, spot diagnosis.
Very good, very good.
It can also elicit giant cell reaction or granulomatous reaction, right?
Sir, if
Can
the
you see this?
sporioles open
This
into the interstitium.
yes. See, you see this? These granulomas, they're almost how they're eating up this sporangiospores. See this?
Yes.
It is sporangia is ruptured, and already the defense mechanism is already there to prevent the engulf and prevent its spread. Can you see the histiocytes how they are well
Acha,
surrounding this?
other than the nose, where else can you get rhinosporidiosis?
Lung,
Lungs,
lungs.
sinus.
Okay, respiratory tract you leave. Anywhere else? Anyway, you get in the urethra.
Sorry, sir.
Urethra. It comes from
Urethra.
water, no? Mostly, and okay. Next.
Diagnosis. Sir already mentioned this case. Big cells.
Cryptococcus proton giant cell.
Okay.
Proton giant. Good.
Okay, supposing you don't have musicarmine or PAS, can you do anything for cryptococcus?
Yes, sir. Sir, we can do melanin, Fontana Masons for.
No stain is available. Special stain.
No stain.
Special stain.
Sir.
That picture is not there. I should have put.
I forgot to put.
Someone is writing India ink. That is
No. What you can do is no stains.
No stains.
Then what you have to do is you have to polarize it. You will get a Maltese cross. This one in cryptococcus. That's another thing you can do. Ajay, somebody has written that you can get rhinosporidiosis in bone and soft tissue. Yes, you can
correct.
get. You can get. Definitely you can get. Those are not very common. Next.
Diagnosis.
Mycosis.
Very good.
Copper penny bottles.
Next.
Sir will take this.
Say, so now you know what, if it is necrotizing or non-necrotizing granuloma, please remember that you must send the tissue for culture and other things. You know, for example, how many fungi can affect a human beings? Any idea?
Sorry, sir.
How many fungi are known to affect human beings? Any idea? How many species total? You know, it's believed around 10,000 are there. But as pathologists, we know only 5. Yeast, that is Candida, then chromomycosis, then we know about cryptococcosis, histoplasmosis, pheohyphomycosis, aspergillosis. Around these 6 we play, whatever it is. But actually there are nearly 10,000. So always involve the microbiology, mycologists. Even in for like they said, no, for tuberculosis, send it for culture, send it for, that is one thing you must do. Then you can do special stains. If you still don't search the slides again, sometimes AFB, some people see for 5 minutes, if you search for 10 minutes, you will get or do more staining and other things. Then you search for blood vessels, other things, do additional studies. Still, there will be some proportion of granulomas we will not be able to diagnose. So we just leave them as it is. We combine the clinico-pathological correlation and then do. Can you just press enter, Sudhir? Okay. You see, I read long time back that there are 3 things. Either we see the cause for the granuloma. For example, you are seeing a foreign body, you are seeing the fungus, you are seeing an AFB on special stains. So that is one group you can make the diagnosis which is etiological. Second is you know the cause. For example, this is a known case of Crohn's disease or sarcoid. You have seen the biopsy. You know this is that lesion only. For example, sarcoid is mainly by exclusion. No AFB, no other organism. The ACE levels are raised. The X-rays are suggestive. Nothing alone helps. So then those are the second set of diseases in which the granulomas, you know the cause. Like in caseous necrosis, there's no AFV, but even then you know this is tuberculosis. So that is the second set of disease. The third is you do not know the cause. So those are the granulomas that always cause a lot of problems, and it's believed is almost 1/3 of the cases, sometimes 10-20%, depending on the institution, where you get more difficult cases and all. You may not be able to make a histological diagnosis, but at least if you tell that this is this type of granuloma, necrotizing, non-necrotizing, and so on and so forth, at least it will help in narrowing down the differential diagnosis, and they'll give some empirical treatment. So this is
Yes,
what we have
they were termed as
tried.
group 1, group 2, and group 3, sir. Very
There are,
earlier.
you see, there are a lot of things, group 1, group 2, group 3, and then which people have described in the granulomas. But you know, for a practical purpose, often many institutions, they don't follow that. So that is why we have not gone into all those details. Today we have tried, if many cases we had to rush up, we have tried to give you an overview of the different types of granulomas and some of the diseases. So we hope you will go back, read, and then use this to build up your knowledge. I'm sorry it's gone very late, and dinner many of you may have missed in the mess or whatever it is, but I hope something you have learned. And Sudhir, I'm thankful to Sudhir for all the help and hope everybody has learned something. Dr. Sharan,
Yes, sir.
this is for you.
Oh,
Anything you
it
want to
was
say?
very elaborate, very lengthy, and in depth about all the aspect of granulomas. And I'm very thankful to Dr. Gupta and Dr. Sudhir, both of you, for giving such a vast experience and nicely dissecting each and then everything. And very good participation by the residents, so
Yeah,
that they
my
did at
claps
least,
to the
yeah.
residents for
Yes, so
Thank
so
you, sir.
that
good
they have,
variety.
it was
Thank
slow
you,
and
sir.
very good. Only the point just we have exceeded some point. There one thing which I wanted to just complete it. Can you, sir, elaborate about the suppurative granulomas? And the suppurative granulomas, and when the necrosis is out of proportion than inflammation, when the giant cells are irregular in distribution, how the resident should approach?
See, most of the suppurative granulomas are because of infections. Most. You can be quite assured. Some suppurative, lot of neutrophils you can get in conditions like Wegener's and other things, but those are rare. So first thing is, when you see suppurative, think of an inflammatory condition, infection, and then you do whatever you want and try to search for the organism. Fungi are first, and then of course sometimes you get the other lesions which can. I'm thankful he has
Yes,
drawn this
so kind of
pointer.
you. So thank you both of them once again, Dr. Suvira and Dr. Datta Gupta. And on behalf of Dr. Sumit Gujral and Dr. Burgess, I have a opportunity to close the session. Thank you for the patience and
Thank you.
longevity.
Thank you
Thank you so much,
everyone.
sir.
Thank you.
Thank you.
Thank you, Devgansh.
Just
Thank you very much, Sudhir and
Thank
sir
you.
and everyone for
Yes,
Alright,
thank you.
Sumit, thank you very much.
He is returned back from